spiritual context of pain. One of the main points about this slide is that we need to have empathy with our patients. Patients that come into the office and patients that are experiencing pain may be experiencing 1, 2, or 3 of all of these things in these boxes that we see here. You know, a patient could be losing sleep, which is now affecting their work ability. They may no longer be able to be intimate with their loved ones because they haven't slept and they're anxious and they're having anxiety and they're having difficulty understanding why these things are happening to them. So we just have to apply empathy to these patients. I unfortunately had a situation recently where I became a pain patient. Never expected it, never thought it would happen. Woke up one morning with the worst radicular pain into my arm. It's a problem with getting a little bit older, I guess, is you wake up with pains that you never experienced before. But when I woke up, I had this terrible radicular pain, didn't know what was happening. Fortunately, I'm in the healthcare setting, so I was able to expedite things quickly, but I still had to wait almost 8 weeks to have surgery to fix the problem. So for 8 weeks, I had pain. And I say I had pain, I had severe pain. And that pain was unrelenting, and it was challenging. It was hard to speak. It was hard to sleep. It was hard to do my job. It was hard to do just about everything. Now, fortunately, I woke up and I was pain-free after surgery, but the reality of it is during that 8-week period of time, I got to experience what some of my patients experience on a regular basis. And I could tell you, I never would want to experience that ever again. And I'm sure anybody in the room that's experienced something like that has that understanding as well. But what we want to get out of this slide here is that patients can experience a lot of these different feelings, emotions, situations, and symptoms that we have to be empathetic with. Patients call up, they're anxious on the phone. The nursing staff is saying to us, hey, this patient's being rude to me on the telephone. They want this, they want that. We have to take a look at that in context and make sure that that's not a patient that's just dealing with some problems that they can't handle at that moment. And we have to be sure that we're cognitive of that and that we're making appropriate decisions about that when it's happening. So we're going to get a little bit in here to pathophysiology of pain. We're going to start with the transduction of pain. This is where the signal starts. It's an activation of nociception at the peripheral nervous system. It converts stimuli to electrical signal that travels the ascending afferent pain pathway. And as it moves on, you're going to go into transmission, which is where the signal goes along the dorsal root ganglion to the second order neuron within the central nervous system. This is where processing of this occurs. Then into modulation, where there's an activation of the descending efferent pain pathway. And it's kind of, you can see it up here, and it's a good diagram of it, of how it actually works. But then it's going to get to the perception portion. This is where the pain signal reaches the brain. This is where the awareness of pain occurs. This is where the maladaptive neural processing starts to happen. This is where the issues start to arise, where patients are really coming in complaining of those pain issues, and they're really struggling to get those things under control. So that's just kind of a brief overview of the pathophysiology of how pain works neurologically within the nervous system. So we have multiple different types of pain, and again, it's important to understand the different types of pain to be able to treat them properly. We have nociceptive, nociplastic, neuropathic, and mixed. Nociceptive pain is pain that's in response to a stimuli. This is typically the acute pain that you're going to see, whether it be postoperative, sickle cell crisis, mechanical back pain, or sports orthopedic injuries such as ACL and different type of injuries that occur in the acute setting. Nociplastic is going to be arising from the altered nociceptive function. This is now typically chronic. Examples of this are going to be fibromyalgia, irritable bowel syndrome, and nonspecific low back pain. And then neuropathic. This is where it becomes a little bit challenging, and understanding these is important because the treatment does change. Pain that develops when the nervous system is damaged. This is typically chronic. Examples of this are going to be postherpetic neuralgia, trigeminal neuralgia, polyneuropathy, CRPS, and radiculopathy. And then mixed is just going to be a duration of both of those, where we're going to see both of those occur at the same time. You could have a mixed component of those. They don't have to be one or the other. You could have somebody with neuropathic pain that also has nociceptive pain. We see that quite a bit in neurosurgery in the sense that patient comes in, they're having significant lower extremity symptoms, but they're also diabetic with diabetic neuropathy. It's important to understand that because, again, if we're going to apply a surgery to that patient, it's important to give them realistic expectations about what to see with that treatment. Maybe their leg symptoms are going to go away, but the burning in their feet is not after surgery. So it's really important to make sure we outline that for them so they understand realistic what they're getting. Just going back to that slide really quickly, there is the possibility of the development of chronic pain after acute injury, and that's kind of what I alluded to earlier in the slides, is that we have to be cautious of that subacute phase because that's where patients are starting to migrate from the acute phase into the subacute phase and then into the chronic phase. We want to be trying to maximize those treatments in that subacute phase. So what is the definition of nociceptive pain? Well, nociceptive pain is pain that arises from the insult of non-neuro tissue. That's the important part of that. With the activation of nociceptors. You can see that there's two nociceptions listed here. It's somatic and visceral. These are pain, well, somatic pain is arising from the bone, joint, muscle, and connective tissue. It's often localized. It can have a referral pattern, and it's best described patients coming in saying that they have an aching, dull, throbbing, or sore pain. Visceral pain arises from internal organs. This is coming from the abdomen, the liver, and the pancreas. This is where we see the chronic and acute pancreatitis, and it's a diffuse, not well localized, and often has a referral pattern. It may be described as gnawing, squeezing, or cramping type pain. Nociceptive pain is expected after surgery, and we've talked about that a little bit, and it's associated with a wide range of musculoskeletal and visceral conditions that include any type of inflammatory, ischemic, infectious, or mechanical injury. So just touching a little bit more on pathophysiology of nociceptive pain. Nociceptive pain, or sensory nerve cells, are activated by a noxious stimuli. Specialized free nerve endings, A beta, A delta, and C fibers are located in the skin, muscle, joint, capsules, bone, and some other major organs. Functionally, they're used to detect potential damaging chemical, mechanical, or thermal stimuli. The best description I can give to you all today is the hand over the fire situation. If you place your hand over a fire, your body's taking that hand back no matter how much you try to keep that hand over there. That's kind of the process in which this works. And it's giving you the ability, or your brain giving you the ability to move those signals along and understand that that's a dangerous situation for the human body. Once activated, it sends a nerve impulse to the spinal cord, which then starts the process of perceiving of the pain. So what's a description of neuropathic pain? Again, these are two distinctly different types of pains. This is pain that arises from damage or injury to nervous tissue. We can see that we have both peripheral and central listed here. Peripheral is injury or damage to a peripheral nerve. This is typically within the peripheral nervous system. It's relatively focal area of involvement. So diabetic neuropathy or something like that, it usually affects the feet. So that's a kind of a good example of that. It can be a referred pattern. Again, it's described as burning, throbbing, and stinging. Central is going to be more our spinal cord injury type patients where they've had a spinal cord injury and it's affected the central nervous system of the human body. And now they're having pain in more larger areas of the body, whether it be from the waist down, upper extremities, things like that. And it usually is described as shooting, squeezing, and aching. So what is the pathophysiology of neuropathic pain? Well, it's the inappropriate response caused by a primary lesion or dysfunction within the nervous system. There's an abnormal excitability that can elevate sensitivity to the stimulus and lead to peripheral sensitization. There's a lower threshold within the spinal cord and cellular membranes, and there's an increased receptor field within the brain. There's prolonged high-frequency C fiber stimulation and discharges that can lead to reorganization of A beta fibers called central sensitization. There's prolonged depolarization of the dorsal horn neurons and changes within the dorsal horn membrane receptors. And that's kind of a nice diagram of it. You'll have access to those slides, but kind of gives you an idea how these fibers work within the human body. So let's take a moment to take a look at a case study here. Janie's a 57-year-old kindergarten teacher. She was diagnosed with shingles about a month ago. She was treated with antivirals and prednisone. Her rash has now dissolved, but she's continued to have pain persistent after the rash has gone away. She describes this pain as burning feeling that shoots up her right arm. The pain alternates between mild and severe. She uses heat, ice, and over-the-counter non-steroidal anti-inflammatories. She states that it kind of helps with the mild episodes, but not so much with the severe episodes. The pain is distracting her and keeping her from staying present. She can't sleep through the night, and the patient is having difficulty with her students in her kindergarten class. Her social history is pretty unremarkable. She's married with one adult son. She enjoys her job working with children. She regularly plays volleyball, so she's a pretty athletic person. She drinks alcohol 1 to 2 times a week, mostly socially. She has a history of smoking, but quit when she decided to get pregnant. And she's been more stressed out than usual because the school board has started cracking down on test scores. Other medical history was otherwise unremarkable. We'll come back to Janie throughout the course of this, so nothing we need to do here other than keep this in your mind and think about some possibilities for her. So pre-test question number 3, in addition to physical assessment, what should you include in Janie's initial pain assessment? A, functional impact of pain. B, PDMP history. C, rapid mood screener. Or D, urine drug screen. So now we're going to take a look at pain assessment, because this is very important. We have to understand what the assessment of pain looks like in order to properly treat it. And looking at that now in this, compared to risk assessment, we can see that pain assessment is a broad concept involving the clinical judgment based on observation, type, significance, and context of individual pain experience, as opposed to risk assessment, which is looking, and we'll talk about that a little bit later, but risk assessment is looking more at this overall process of hazard identification, risk analysis, and risk evaluation. The portion to the side there, the pain assessment, we're going to go through that in the next slide, so I'm going to just kind of really pay attention to this slide here. But these are all the questions that we should be asking patients, right? And these are all the questions that we should be documenting in our notes in order for patients' picture to be painted in terms of what kind of pain they're having. So I am going to walk through each one of these because, again, as I stated earlier, when we talk about opioids and we talk about that fear and we talk about that concern about prosecution, documentation is everything. And in all the cases that I've had an opportunity to review, the clinicians documented well enough like this. And they've included all of these factors in those documentations, which allowed us to say, this is somebody that was really trying to do their very best to treat this patient. So let's start with location. Well, that's pretty self-explanatory. Where's the pain? Tell us where the pain is. Tell us where the pain goes. And kind of really be as specific about that as possible, because that's going to help you fish things out moving forward. History of onset. When did it start? Was there an injury? Was there a trauma? Or did this just come all about? And they can kind of guide you in terms of direction. Now, it's important to keep patients on track because you might end up 40 years down the road. You know, it's hard to get there sometimes, but maybe talk to them in 10-year segments. You know, what's been going on within the last 10 years, and really kind of gathering that history. Quality. What does it feel like? You know, and this is the descriptors that we're going to need to determine what type of pain we're dealing with, so that when we initiate that treatment, we're initiating the appropriate treatment. Intensity. How intense is your pain? Talk to us about, is it more intense in certain areas, more intense at different times of the day? What's the worst, what's the average, and what's the best? And document those things so that you have an idea of what might be best suited from a treatment standpoint. Temporal pattern, is it constant or is it intermittent? That's important to know also, because again, your treatment is going to be dependent upon how that actually looks in terms of their actual pain. Aggravating factors and alleviating factors. What makes it better? What makes it worse? Tell me what happens to you when your pain is at its worst. Are you doing activities? Are you playing with your grandkids? Are you doing something that's causing your pain to be aggravated? What makes it better? Sitting on the couch maybe, or doing some activity outside of just sitting around may make their pain better. So associated symptoms. Are you experiencing any other associated symptoms with it, like nausea or any other type of incontinence issues? Because again, looking at it neurologically, that could be a concern if they're having incontinence issues. Previous methods of treatment. What have you tried in the past? Again, we don't want to be reinventing the wheel when treating these patients. We want to really kind of focus on what may work best. And if we don't know what they've tried in the past, that may be very difficult to do. It's not that you can't reinitiate treatment at a later time to try to get it to be more successful by changing things with that treatment, but it's really saying being cognitive or aware of what that patient's actually been taking over time. And then the impact of pain on the quality of life. And this is very important because, again, this is where we start talking about goal setting, right? This is where we say, okay, so you can't do anything at all currently. You're not able to function at home. You can't wash your dishes. You can't do these type of things. Once we initiate treatment, our goal is going to be coming back to that and seeing what functional improvements we've actually made with that particular type of treatment. And that's going to be very important in documentation, because if you come back 6 months later and you don't document what exactly was the impact on their quality of life, it's really hard to kind of quantify what you've done from a treatment standpoint. Are they sleeping better? You know, what are some of the most basic things that we need to be addressing from a quality of life standpoint? What to look for in a patient history? Well, this is very important too when you're treating pain patients. And I'm going to start kind of at the top on the medical and treatment history. Non-pharmacological and pharmacological strategies to date. All treatments, what treatments have they had? How have they been successful, or how have they been unsuccessful in those treatments? Relevant illness. You know, have they suffered from multiple episodes of pancreatitis or other medical conditions that result in a worsening of their pain symptoms? Other current prescriptions, what are they currently taking now? Because if you're going to be thinking about prescribing a medication, whether that be opioid or non-opioid, it's very important to know what they're currently taking so that there's no contraindication to starting that medication, and so that you're not setting yourself up for an adverse event occurring for that patient. Past and current opioid use. So if you're considering an opioid for sure with this particular patient, you're going to want to make sure that you query the PDMP, and in Pennsylvania we have that available to us. It's very nice. It's very easy to use in my opinion, and it tells a lot. I always tell healthcare providers, I still sit on the Pennsylvania Pain Society, and we do a conference every single year. And at that conference, it's a room full of anesthesiologists and pain physicians. And one of the things that I get very commonly is that PDMP, it's not being used for that gotcha moment. You know, I got you, patient. I found out you were using this or you were doing that. That's not what we want to use that for. We want to use that as a guide to help us understand. Now, in some cases, it does provide us information that maybe the patient was not really forthcoming with, and that's okay. We confront the patient with that information, and we have a real conversation with the patient about those things. So very important to kind of really look at that as an option from a PDMP standpoint. It can be a lot. It can tell you a lot about a patient too. Okay. Obtain prior medical records. And again, this is something that when I was practicing pain management for over 12 years, one of the things that was which I thought was to be a big problem, was monitoring all these records coming in. We would get tons of records, and we would be reviewing them as the healthcare provider. And you know, just like I do, that every day is challenging getting through clinics and making sure patients are taken care of properly, and having an abundance of records to manage after the clinic to look through and decide if a patient's appropriate is very challenging. But it's important because it will tell a tale about the patient's history. It will tell you what the patient has done. And it's going to make you aware of whether or not that patient is a patient that you really want to take on in the healthcare setting, and it's somebody that you may not want to take on if there's some information in there that's somewhat concerning. And I always confront the patient about that information, right? Because it's their medical record. It's there. They should know about it. And I want to know what happened. I want to know what transpired. Sometimes it's confrontational, sometimes it's not. But we have to have that real conversation about what those things are, because sometimes they're not always what the paper says, and they can be misinterpreted. So it's important to kind of have that conversation with your patients. And determine whether or not the patient is opioid tolerant. You can tell that through the PDMP. You can tell that just based on getting a history with the patient. And then lastly, what are the current opioids being used? Note the dosage, the regimen, and how much they've been using and what the duration of their usage was. That just gives you a general idea of how they're responding to opioid therapy altogether. So looking at social and psychological history, you know, are they employed? Are they maintaining gainful employment? Is this somebody that's skipping jobs every 2 weeks? Is this somebody that's really not being able to hold down employment. Again, we have to be very clear about why that's happening. Is it because their pain is so severe they can't function properly and they can't hold down the job? Or is it because they have maybe a substance use disorder where they're not able to hold down that job? So it's important to really kind of work through those psychological and social histories. What do their relationships at home look like? There's been plenty of times I've asked patients to bring their loved ones into the exam room with them so that we can sit down and talk, because you get that story from the patient and then the wife or the husband comes in and it's a completely different story about what their function looks like. And most of the time it's the patient minimizing what their symptoms are. And then the husband or wife comes in and then they sit down and you say, well, or significant other, and they come in and they sit down and they say, no, he can't even get out of bed, or she can't get out of bed, or they can't get out of bed on a daily basis. I watch it. It's tearful. They can't play with our kids. They can't do this. They can't do that. And then you really kind of get the true story about what's happening there. So very important to get that history as well. Now, psychological, of course, we have to look for conditions that kind of work concurrentently with the pain side of things, and that's going to be depression, anxiety, PTSD, and what are their current treatments for that? Because I probably have spent more time talking to psychologists and therapists on the phone about patients that I've been treating from a chronic pain standpoint, because we have to work concurrently to ensure that the patient's mental health is as stable as their physical health. And if those things are not working together well, the patient's outcomes are likely not going to be as positive as you want them to be. Are they using alcohol, tobacco, and other recreational drugs? Very important, and I think we all know that that's part of the history that we need to be taking. Some of those things need to be prohibitive when we're thinking about writing opioid medications because of the combined effects of those things. This is one area. The next one is one area that I don't know that I've ever paid as much attention to that I should have, and that's the history of adverse childhood experiences. What has a patient experienced in their life, as a child? Is there something there that could potentiate a situation where they are a little bit more prone to maybe substance abuse disorder? Or are they prone to minimizing pain because they have somebody at home that maybe raised them to be strong and be, not really talk about their emotion or talk about their pain? And so those are things that we have to be cognitive of and things that we have to approach the patients about in an effort to kind of get this information out of them to be able to treat them properly. And then, of course, lastly, family history of substance use disorder and psychiatric disorders. I tell this story probably at every lecture I give. I'd like to think it's the only time I've been duped, but I had an 84-year-old woman present to me in the office, and it was probably about 3 years, maybe 3 to 5 years into my practice. And she sat down with me. I was convinced that she was suffering pain. Her physical exam was positive. The forward flexion was painful. She gave all the right signs. The nurse comes to me one day and says, I'll just use Betty Smith, but Betty Smith's urines keep coming back negative. I go, I know, I saw that. I'm not sure. Maybe she's just not taking the medicine. Let's get her in. Let's talk with her. Or let's get her and do a pill count is what I did. And so they bring her in and she doesn't show up for the pill count. I go, well, this is weird. So they bring it back to me and I go, okay, get her in for a visit. Like, we need to sit down and have a conversation. So she comes in, and immediately upon me entering the room, she is just tearful, just waterworks. And I said, well, Ms. Smith, what's wrong? She said, I know what this is about. And I go, okay, well, let's talk about it. What's happening? It's just my grandson. And I said, well, tell me about that, because now I'm thinking elder abuse, and I'm starting to worry about some condition where she's being manipulated. And in fact, she was. So her grandson actually was telling her that he was suffering chronic pain and no doctors would be willing to treat him because of his age. So she felt obligated to treat him. She felt the need to seek those medications so that that person that she loved and cared for would be able to function daily. Now, of course, that's a big concern for us, and that's something that I had to address with her. And of course, I could no longer write for her. But she understood, and she knew what she was doing wrong. But it was still something she did because it was her loved one. And that loved one was really kind of putting the pressure on her to seek out those medications. And I do like to believe that was the first time I was duped. I don't know, but I felt badly for her because she was legitimately trying to do something nice and careful for her family members. So getting that family history of substance abuse disorder is extremely important, and that's why, because sometimes, and maybe it wouldn't have come out in that particular scenario, but it may come out as you talk with patients about their histories. So what does a physical exam look like? I'm not going to go through how to do your physical exam. I think probably everybody in the room knows how to do a really good physical examination. I am going to focus on two areas, which is going to be the musculoskeletal and the neurological exam. I think these are very important from documentation standpoint. Again, we want to make sure that we're documenting where we're being able to elicit pain from the patient. We're bending them forward, we're doing forward flexion, we're doing extension, the patient's experiencing pain in this particular range of motion pattern. And documenting that as well as we can in order to show that we're able to classify this diagnosis and we're able to prove that this diagnosis exists. I see neurological exams all the time where patients come in and their exam was completely normal. And I examine them and they're hyperreflexic and I go, whew. That's something that we have to do better at in terms of documentation. So it's just something to look at from a physical exam standpoint. And I think it's really important to document that, even going back to the less important reason about our fears about prosecution or observation from the government or government agency. If you have a good physical examination documented, it shows validity in what you were seeing. You can take subjective information and turn it into objective information, which is much more sustainable in the discussion. We can order the appropriate diagnostic test based on the history and physical. So once we gather all this information, what do we need to do to now really determine what diagnosis exists there? Are we getting MRI scans? Are we getting CT myelograms? What are the tests that are needed to really put you to the next step in making these determinations? EMGs for neuropathic pain. Do we suspect some neuropathic process that may be coupled with some nociceptive issues? And how do we distinguish those two? EMG electrical testing is very helpful in those instances. So something to think about from a diagnosis standpoint. So what we have here is a pain assessment toolbox, and I'm going to talk about the ones that I think are used most frequently throughout things. And the two that I like the most are listed here, which is the brief pain inventory and the universal pain assessment tool. And these kind of help patients, and they're kind of the easier ones, in my opinion, to have and to process in a clinical setting that will help you identify where the patient's pain is, what's the intensity of it, and then quantifying that with what they say to you, and really kind of pulling all of this together. And then the functional assessment for older folks, we like to use the geriatric assessment and the PPS. Now, again, as I spoke about earlier, I think in my practice, one of the things I didn't focus a whole lot on was the advanced, the psychological or the childhood experiences aspect of things. So there is a tool out there that's available to you, and it's the Adverse Childhood Experiences tool, and that's listed here as well. And then the assessment in advanced dementia, if you have somebody that may be suffering from a diagnosis of cognitive impairment or something that much further like a dementia or Alzheimer's, this might be something that you apply to them to try to help understand their pain a little bit better. And then lastly, the psychological measurement tools. Our psychological colleagues typically use these more frequently, but I have used them in the past, and that's going to be your PHQ-9 and the GAD-7. So going back to Janie for just a minute, looking from a pain assessment standpoint, the description of her pain is that the pain is burning that shoots up her right arm into her shoulder and neck area. It began 1 month after the shingles and has varied in intensity, so it's kind of waxed and waned between mild to severe. She tried and has had some success with over-the-counter non-steroidal anti-inflammatories for the mild to moderate type of pain, but not so much the severe pain. And she also states that ice can be helpful at times. What causes the pain to increase? Well, the stimulus, but when her kids bump into her or the children in the kindergarten class bump into her, that becomes more painful for her. So she tries to keep her distance as much as possible, which is kind of different for her because Janie used to be very interactive with her kids. So you can see that that's now playing a role there. And her current pain level is a 6 out of 10. So I think we can all make the diagnosis now of postherpetic neuralgia. That's a neuropathic condition, and it's affecting her that's occurred after the shingles. So postherpetic neuralgia typically follows a very specific dermatomal pattern, and it's something that we see usually developing about almost immediately after the rash, or even sometimes when the rash is still there, but it's kind of hard to distinguish that while you're treating that rash because that's the acute phase of things. So postherpetic neuralgia was the diagnosis for Janie. So pain management, how do we treat it? What are the treatments that we're going to have available to us? So we're going to run through both pharmacological, non-pharmacological, and some different types of multimodal approaches to the treatment of pain. So for the pre-test question number 4, you can see here we have A, opioid-free approaches, B, in line with biopsychosocial module of pain, or C, only necessary for patients with moderate to severe pain, or D, not recommended by the U.S. Department of Health and Human Services. So we've seen a paradigm shift, and I'm not going to spend too much on this slide, but I think it's important to understand what we're trying to do when we're treating pain patients, and that's really kind of move them along and improve their overall function. And we can see if there's a decrease in pain, there's an obvious improvement in function, or at least we like to believe that that's the case. We want to make sure that we're making absolute certain that that's happening in order for pain treatments to be effective. The lack of functional improvement always indicates treatment failure or other problems such as misuse, diversion, addiction. You have to wonder if you're prescribing a patient, 20 oxycodone tablets a month, and they come back and their pain is no different, or there's some, no real change in their actual function. Are they taking the medications like the scenario that I produced earlier today? Is that something that's happening, and we need to be aware of that. So that might be an indicator to you that things are not as you thought they were. So the development of a treatment plan involves multiple different steps. The clinical assessment is one of them, and that encompasses everything that we've kind of talked about just a few moments ago. That's going to be the physical examination, the diagnostic imaging that we're obtaining, the pain assessment and history, the past therapeutic trials, and the risk assessment tools that we're going to talk about in just a little while here. Expectations and goals, and I cannot understate this. This is extremely important to do when you're treating chronic pain, and that's set realistic expectations with your patients. Have them understand what is going to happen with the treatment you're going to do, or what you expect to see out of those particular treatments. If those expectations are set up front and early, it makes it much easier for you, the healthcare provider, to manage that patient as things kind of progress through things. Monitoring plan. We got to have a good monitoring plan in order to protect ourselves and in order to protect the patient. And that encompasses, monitoring for adverse events. Is the patient having any side effect or problem? What is that patient experiencing with the dosing and prescriptions that we're prescribing to them? Assess the treatment progress. Is it getting better? And you have to come up with that as an individual clinician about how often you're going to look at those things for that patient. Are you going to see them on a monthly basis for the first 6 months and then maybe move to a yearly, or maybe move differently once you've been able to establish good therapeutic care? Check the PDMP, urine drug screens, and pill counts. There are so many different documentations out there about how we should be doing these things. And I think we're going to talk about that a little bit later here too, deeper into the slides. But I think it's important to get the very basic understanding that performing urine drug screens, performing pill counts, and checking your PDMP are going to be very essential parts of what you're doing in order to protect yourself as well as the patient. So very important part of this. And all of these things are really quite easy to do. They're not very difficult tasks to do. And there are guidances out there on how often to do things like urine drug screening. The CDC guidelines have now placed some discussion in their documents about how often, and we'll probably talk about that a little bit later. Patient education, extremely important, right? We as clinicians have some obligation to ensure that we are educating our patients. And that's important to be done both by discussion in the office room with them, but also as handouts, printouts, things that they can take home so that they can reference it later after we've left the room or after we've moved on to the next patient. They have something to reference about our discussion. AI technology has been something that's kind of coming around quite frequently, and that has added a component of patient education. I haven't myself dove into it much, but I know that there are some studies going on right now looking at the triaging of patients, looking at the understanding of how patients progress through the healthcare system via AI technology. So might be something down the road that could be coming our way. So very interesting. So what are treatment goals for different types here? We have acute pain, chronic pain, and palliative care pain. These are all different types of pains here. And for the acute pain phase, we're trying to treat and facilitate recovery and healing. We want to minimize the impact of the pain, minimize how much is causing a disruption in their life during that acute phase. We want to reduce the pain intensity. We want to provide recovery focused on rehabilitation. We want to improve the quality of life during that acute phase, as I said earlier. We want to minimize the adverse events that can occur and then prevent the transition to chronic pain. And I think I talked about that enough earlier. We want to really look at that subacute phase and make sure that we are trying to protect that patient from moving into that chronic pain phase. Because once they get into that chronic pain, it's a little bit more challenging to get them out of that area or out of that particular classification. Looking at chronic pain, the objective and the goal of treatment through chronic pain is to restore function, physical, emotional, and social function. So that's looking at all function of the patient, ADLs, their ability to function at home, their relationships at home, and some of the things that we talked about in the earlier slides. We want to reduce the pain intensity as well. We want to treat the underlying cause of pain. Is there other, does the patient need a consult with neurosurgery, or does the patient need a consult with GI to discuss some of the things that could be done to help alleviate some of the pains that they may be experiencing through their life? We want to improve their quality of life. I think that's something that's kind of going to carry through these slides, is that our main objectives and goals here is to improve their quality of life. And when they suffer pain, that's sometimes difficult to do. And I think that's a reaching goal that we have to be aware of and something that we have to try to do. And of course, we want to minimize adverse events. Correct the consequences of pain. What happens to a person when they develop pain? What do they start doing? What does their body start to morph into? Are they now having postural deficits? Are they starting to hunch over because their back hurts them so badly? Now they're using assistive devices to walk every day, and they're really starting to morph into this different body style in terms of, walkers and wheelchairs. And these are patients that are now transitioning their life into all these different assistive devices just to try to get through their day. And then maladaptive behavior. We need to make sure these patients are dealing with good coping strategies, and they have a means of getting with their, counselors or psychologists. And if they don't have one, we maybe need to make that referral so that patient can develop good coping skills, because they may be in this for the rest of their life. And that's a very daunting conversation to have with a patient, sitting down with them and saying to them, look, you are now suffering chronic pain and this may not go away. If they don't have good coping strategies, I'm sure all of us have seen somebody like that. And that's not something we want for our patients, and that's something the patient doesn't even want. So we want to make sure that we're able to help improve that maladaptive behavior and coping. Palliative care, manage the symptoms. We want to relieve the pain and other distressing symptoms associated with it, whether that be nausea, vomiting, any other type of symptoms that could be going on. We want to, again, optimize quality of life during this period of time. We want to provide comfort care with or without intent to cure or to reach a cure. These patients may not be curable. And maybe we're having that discussion in terms of we're just trying to be comfortable now, and we're making those decisions to be comfortable. And our role is to help facilitate that. So it's something in palliative care that's very important. Supportive systems for families. These families get exhausted. They're tired. They're agitated. They're upset. Their loved one is going through something very traumatic. And again, I think that we have to, as a country, not just as a room here today, but as a country, understand that chronic pain is no different than any other chronic illness, like diabetes. We focus on heart disease. We focus on, all these other chronic long-term conditions. But I think we have to, as a country, start understanding that chronic pain is equally as important and sometimes more costly to the healthcare system than is some of these other chronic illnesses. So, it's a role that we all have to take on. I talked about this a little bit earlier, but I will run through this again. But we want to be setting realistic expectations for these patients. We don't want to tell them, look, I'm going to give you pain medication today and your pain is going to go away. That's not realistic. We know that. Maybe it happens. I've seen it happen. But I don't know that that needs to be the expectation. The expectation should be, look, we're looking at about a 20 to 30% reduction in your pain as a success here. I like to say 50. I don't know why that number sticks good in my head, but I usually use that 50% mark. I want to see a reduction of 50%. But don't get hung up on the percentages because, again, we have to take that functional improvement and apply that functional improvement, right? We have to say, okay, maybe the patient's only getting 10% relief of their pain with that pain prescription. However, they've been able to stand and do their dishes, which is something they haven't done in 20 years. That's a big deal. That's a big step for a patient that's been suffering chronic pain. So we have to be sure that we don't take those numbers and say, well, this is the number, this is where we need to be, and this is where if you don't strive to get there or you don't get there, then this isn't a successful treatment. That's not true. The truth in it is get the functional improvements, document the functional improvements, and that's success in itself. A nerve block, and we're going to talk a little bit more about interventional treatments available, but nerve blocks or injections are a one and done. Go get the shot, you're going to be better. No, I've been in pain management and have some of the best pain colleagues in the country, and that they've never given an injection that has actually, essentially cured the pain. There's been some occasions where patients improve and they do better, and sometimes they get better for long periods of time. But the reality is the expectation cannot be it's a one and done. You may need multiple injections to get through there. And then pharmacological approaches alone will manage pain and restore function. Again, we have to use a multimodal approach to ensure that patients are improving. That includes maybe some injections with some medications. Those two things can be used together in an effort to treat the patient. There are some topics we're going to move on to here that are less aggressive or invasive as injections, and they are very helpful in the treatment of chronic pain. I'm not going to spend a whole lot of time on this slide. It is very busy. You guys will have access to it again. But this is what's considered the kind of the overarching toolbox that we use. And each patient, and the goal of this particular slide is to say that each patient may require different treatments, and they could require a combination of different treatments that suit them as the individual patient. And under our toolbox, you can see a laundry list of different treatments that we can use. And we're going to go through some of these today, but not all of them. So you will have access to this slide as well. But you can see that each one of these patients ends up with a very distinct and different treatment plan that suits them best. And that's what our goal is to take this toolbox and apply it to our patients that are coming in with these chronic pain issues and hoping that they improve and become successful in their treatment. So, consideration when choosing treatment modalities, what type of pain are we treating? And this is very important. This is very important when we talk about both chronic and acute pain and also nociceptive and neuropathic. What we found over the course of many, many years, and it's well documented in the literature, is that neuropathic pain does not respond well to opioid pain medications. And for years, when I was in pain management, I would have patients with diabetic neuropathy that would come into our office on astronomical amounts of opioid pain medications. And never were they really successful with those dosages of medications. Now, some of the patients that have mixed pain, yes, you can find success. But in straight neuropathic pain, it's very rare that prescribing opioids are going to be helpful in these cases. So you have to keep that in mind. It's very important. So the rationale is it opioid necessary? What are we trying to achieve? What are the what are the functional goals that we're trying to meet? And does the benefit outweigh the risk? Because these are risky drugs to use, and you have to be aware of what their risks are in order to be able to properly assess if there's going to be an issue with those risks. And treatment history, different modalities. What were the effectiveness or efficiency of those? Has the pain changed, or has there been a new pain related to trauma? Social history, and we went through some of these things earlier. We have to pay attention to the family history of substance use disorder and tobacco usage, and what does their PDMP look like? What does their initial urine drug screening look like? There was a time in my career where I would prescribe the medication on the first visit. If I saw the patient, I thought the patient had a legitimate diagnosis that was confirmed by other diagnostic tools, I would prescribe the medication and then do the urine drug screen that day and get the results back later. Well, I stopped doing that. I started saying, we're going to get your urine drug screen. It'll be back in 24 hours. I will send you a prescription once I've had an opportunity to review that screen. Nothing wrong with that. If the patient gives you a pushback on that, we got to start thinking there's some other concern there. And so, it's not something that we have to be overly concerned about, but it's something that we need to be cognizant of. Comorbidities, does this person have sleep apnea? This is a big thing. If you give patient an opioid medication and they take it before bed and they have an undiagnosed sleep apnea, or they have a severe sleep apnea and they're not maximizing their sleep apnea treatment, you can have respiratory distress and respiratory arrest. So important to kind of understand that those conditions or those comorbidities and those concurrent conditions can play a role in your decision-making at that particular time. And then the age-old discussion about benzodiazepines and opioids, right? So everyone, I think this has been something, and this stems from the CDC guidelines that occurred in 2016, which was under no circumstances, and I think that was pretty much how they stated it. I think you could probably agree that under no circumstances were you to prescribe an opioid in the presence of a benzodiazepine. Yeah, that's true, and to some degree, but also if it's a patient that's been chronically controlled with our psychological colleagues and they're being managed properly and you have a good communication like I spoke about earlier with those colleagues, I don't see a problem with it. Now, I watched that patient, we observed that patient a little bit differently, but I don't know that it's an over concern as long as there's good specialists involved on both of those fronts. Patient preference, route of administration, what makes it easy for them? What's going to increase their compliance? Job concerns, patients with CDLs, right? We have a big concern, like what do we do with patients with CDLs if we give them an opioid? Do we just entirely change their career? It's not that simple. So we have to be cognitive of those things as well. And that's just one example of jobs. There's plenty of jobs out there that could certainly be of a concern. Take us, for example, healthcare clinicians. We are all human. We all suffer pain. During my episode of 8 weeks, I did everything I could to not take an opioid pill because I wanted a clear mind. I didn't want to be under the influence of an opioid pain pill. But I can tell you that at some point I broke down. And there was just no other option at that point other than to treat myself. That resulted in me taking time off work and not treating patients, but that's what I had to do. And that's okay, because we have to take care of ourselves as well. So it's important to kind of look at those things as well. Back to Janie again. So what we've determined is she's got postherpetic neuralgia, which is a chronic neuropathic pain condition. The rationale is Janie is suffering more than just physically from her pain. She is nervous to interact with her students for the fear of aggravating the pain, and she's not sleeping well, which as a teacher, we all know you probably need to sleep well to be on the top of your game. And so the goal is to reduce her pain, to constantly mount or limit the flare-ups, and regain her sleep schedule and the love for her job. So that's going to be our health, that's going to be our goal. So we're going to take a look at a treatment for her, but really that's going to be kind of the goal for Janie here. What's her treatment history? She's not really tried anything other than the over-the-counters that we talked about earlier, non-steroidal anti-inflammatory over-the-counters. Social history and risk assessment. She drinks socially, probably something that she could probably stop doing in the sake of treating her symptoms. No family history of substance use disorder that she is aware of. Comorbidities and current medications, there's none. And then patient preference, needs to fit into her work schedule. She prefers oral agents if necessary. So, another topic, when to refer to a specialist. So, I think a large amount of us here today are family practice, I would assume, based on everything. So it is difficult to understand exactly when is the time to make that appropriate referral. But what I'm going to go through on this slide is the different type of consultation types. What are the different roles of that specialist that can be helpful for you as the family practice. Family practice clinicians are the most important part of the patient's care, in my opinion, and that is my opinion, because there's not been a single time where I picked up a phone, I don't care if it was 7 o'clock at night or 9 o'clock at night, to one of my family practice colleagues to discuss a patient that they not know everything about that patient. I have to open up my computer, I've got to get on there, I've got to type some stuff. Within a few minutes, they're telling me about this patient. And family practice providers are really knowledgeable about patient's care. So there are times now where specialists come into play, and these specialists are important because when we're talking about opioid pain medications, it can become a little challenging to manage those in your clinics and in our clinics. So there are different types of different referrals that can be made, and that's a consultation where you're sending it over just to really get their opinion from the pain management specialist and say, hey, I'm thinking this is what's happening. I'm thinking this pain treatment. What do you think? What's your opinion on this? And that's just something merely like a communication. Maybe the consultation comes back in the way of an office note that stays in the patient's chart, and that provides good evidence that you've done your due diligence to ensure that what your treatment protocol was appropriate. Specialty care, to perform ancillary service. Do you need physical therapy? Do you need injections? We can do trigger points. We can do different types of very localized injections in the office, in the family practice setting. But something deeper like an epidural steroid injection or nerve root block or facet block, these are things that we're going to rely on our colleagues for to get those things completed. So we'll be making that referral maybe just for that particular type of care. Co-management. Are we doing this together? Is there a pain management provider that's managing the injections while the primary care doctor is still managing the opioid pain medications? Or let's not even use opioids, maybe a gabapentin or something like that. Maybe there's some concurrent management going on there where both of us, and I like communication in these instances. I talk to primary care doctors all the time. I talk to specialists of all different types all the time, even though I'm in a specialty now. It's important for that communication to occur in order for that patient outcome to be improved. And then taking over. Well, the specialist can take over everything, right? So we can say, hey, look, I'm just not comfortable with this patient. And that's true. That's true. That can be true a lot of times. And as a nurse practitioner, there's been times I've asked my attending to take over a patient because I wasn't comfortable with those things. Maybe just the complexity of the patient. Maybe there's just a lot going on there. And there's some things that just don't make you comfortable as the individual clinician, and that's okay. But we still have a role to treat that patient. So passing that patient off to that specialist is reasonable, okay? This red box here is for a reason, so I'm going to read this off here. You should not refer to specialists for the sole purpose of wanting to prescribe opioid medications or because there's a stigma surrounding opioid medications. When the CDC guidelines came out in 2016, there was a large amount of people, I should say in all settings, because pain management did it too. There were pain management physicians and providers that were not writing opioid pain medications. So it became very frustrating for the referring physicians and providers that were sending patients over because even the pain was saying, we're not doing that either. And you're like, well, wait a second. So now we're just doing injections. But there is a role for specialists, and there is a role. That statement there is something that is really meant to just kind of understand that you don't need to make that referral just because an opioid's being utilized. We're all qualified physicians and providers to do those things. And if done right with the right education, there's no reason why it can't be managed. So I'm going to skip that slide because we kind of went through all of that there. So, and we're time-wise, we want to kind of stay on track here and we'll get you guys to lunch. So non-pharmacological approaches. So here's a pre-question number 5. What is true of cognitive behavioral therapy for pain management? A, it falls under the umbrella of complementary alternative medicine for pain. B, it is only effective if patients are motivated to put in the effort during the sessions. C, it is the least evidence-based non-pharmacological approach. Or D, it is the most cost-effective option for most patients. So why try non-pharmacological options for chronic pain? Well, I think there's a lot of obvious statements in here, but the biggest thing is that the risk of doing opioids and the risk of doing or having treatments that are not being done concurrently can really put the patient at a risk. And maybe we just try other things first to get the patient to a better pain process and allow the patient to be a part of that decision making. And maybe it is just an opioid at some point, but really to combine the efforts of treatment is important. And non-pharmacological treatments can be as important as pharmacological treatments. And we have to be aware of what those are. We'll go through them here in the next few slides. Fundamental self-management and whole healthcare. I think I spoke about this earlier. We really need to kind of be empathetic to patients, but we also need to empower them to make decisions about their care. And that empowerment does lead to more patient outcomes or better patient outcomes over the course of time. And these are just strategies that are listed here. Like I said, you'll have access to these later, but these are really just kind of strategies in which you can utilize to help that. So what are some evidence-based non-pharmacological treatments that we can utilize? Well, there's many options, and there's an array of different type of evidence and degrees of evidence that support these things. So the literature is out there. It's sporadic, but it's there. There are different ways to kind of look at these things, but in general, active self-based care is preferred over passive care. Patient preference and agency along with shared decision-making guides the decisions for treatments, and that's what's going to be important. So what's appropriate for the patient? Can we use exercise, yoga, Tai Chi? Are these all modalities of movement that can be helpful and successful for the patient's treatment? What are some complementary alternatives? Acupuncture. Work with some of your colleagues, chiropractic colleagues, that may be able to help with some manipulation or different types of treatments that are reasonable from a chiropractic standpoint. Massage therapy. A lot of patients respond very well to massage therapy, and a lot of it has to do with their muscular component of pain. So massage therapy. Now, again, can be a little cost prohibitive, and we're going to talk about that in a moment, but that is something that you can try or at least utilize as a modality. Cognitive and behavioral therapies. Those are very helpful, and there is evidence out there that those are being utilized more often. The research is really showing that it's coming around to a point where it's very helpful for patients. It's becoming much more accessible to patients. Neuromodulation, non-invasive uses of neuromodulation, but also invasive uses of neuromodulation, such as spinal cord stimulation. If you're not familiar, that's a device that's utilized to really kind of help with chronic pain issues. So let's take a moment to take a look at cognitive behavioral therapies. What are the pros? Well, it actually results in actual changes within the brain's neural pathways. So we see actual changes within the pathways of the neural system. It's long lasting, and there's good evidence to support it right now. So it has come around quite a bit over the last 5 to 10 years, I would say, in terms of the actual treatment of patients with chronic pain. What are some of the cons? Well, it takes practice and motivation, and the cost of it, of course. Some of these things can be cost prohibitive for patients. They're not wealthy because maybe they're off work because of their pain issues, and some of these things are helpful to help their pain, but become out of reach because they're a little bit too costly. Nutrition, well, we don't have a whole lot of evidence around nutrition and what it does in terms of the treatment of chronic pain, but we do know that antioxidants and things of those natures can really be helpful in terms of the treatment. There was a medical food drug, and I don't know if any of you are aware of it. It was called MEDX, B12, B6, and folic acid. Probably one of the best drugs I've used for neuropathic pain in all of the treatment that I've done on patients for that type of condition. And it's basically a medical food. It's a nutrition. It's something that's utilized. So nutrition is something we can use. And then obviously the discussion is in there about weight reduction. That comes up. And it's not something that we should focus on as the main way to resolve a patient's pain. I've had patients come in multiple times telling me that, their healthcare provider told them if they lose 20 pounds, their pain's going to go away. Well, number one, that's an unrealistic expectation. And number two, that's not going to happen. Losing weight is going to help their function. Losing weight is going to help their inflammatory process, but it's not maybe going to take away their pain. So looking at the complementary alternative medicines, the acupunctures, the spinal manipulation, and the massage therapies, I'll let you folks read through these, but what we do know is there is moderate amounts of evidence available to support these things. We do have some concerns or issues related to costs of these. It's very difficult, again, like I said earlier, with patients that may be off of work because their pain is so severe, to go out and get acupuncture that can be a little bit expensive. Now, insurance companies have come around. They have been, paying for chiropractic care a little bit more. They have been paying for acupuncture in some cases. So it might be something to look into and see if the healthcare plan for the patient is covering that. Neuromodulation. I think all of us are probably familiar with TENS units. They are now over the counter. I think you can buy them at Walgreens to some degree. You can still prescribe them. I'm not sure that they're covered by insurance much, and a lot of that has to do with the lack of evidence for long-term effectiveness. So I think that the companies have now come to the realization that they're going to let them be over the counter. And they are a nice way, and they're utilized. And I used one myself, and I think for the time that it's on, it's reasonable and it makes sense as a non-pharmacological approach to the treatment of pain. Invasive neuromodulation, that's going to be a little bit different. This is where spinal cord stimulation comes into play. We use spinal cord stimulation for a lot of different conditions, patients that are non-surgical, patients that have diabetic neuropathy, patients that are suffering from some pretty severe chronic pain issues. This entails putting wires into the spine which override the nervous system. It's built off a theory from Melzack and Walls of the gate theory, if anyone's familiar with the gate theory. It really kind of overrides the ability of the body to produce those malfunctioning pain signals. Kind of give a good example, if you hit your elbow on a desk, hurts really bad, you rub it really hard and pain goes away. It's kind of how it works in the body. So it's shutting the gate of all those abnormal flooded signals to the brain. So spinal cord stimulation can be a very useful device in a lot of cases of patients that are suffering from chronic pain. Most of your pain management colleagues that are around you probably do spinal cord stimulator troweling. Typically neurosurgery implants those, but there are some pain providers that are implanting them. So, reach out to your pain management colleagues if you have a patient that you're challenged with that is not getting better. Maybe spinal cord stimulation could be an option. And then intrathecal therapy for cancer pain. Intrathecal pain drug pumps are very successful for the treatment of malignancy pain. They're also used in chronic pain. So it is something that may be available for a patient if they've failed other more aggressive type of therapies. Here is a list of invasive and interventional therapies that can be utilized. I'm not going to run through those, but I think we're all familiar with the pain management techniques of facet blocks for axial lower back pain, nerve root blocks for radicular pain, epidural injections for patients that are suffering from spinal stenosis, joint injections for knees and elbows and wrists and things of that nature. We talked about spinal cord stimulation, and then finally trigger points, which is something that a lot of you may do in your office as a treatment for the patient, is a muscular injection, which is termed a trigger point injection. So what did we do for Janie? Well, we did an approach where we used a couple different things, and that's going to be gabapentin, which is an FDA indicated drug for postherpetic neuralgia. We were able to titrate her up to 900 milligrams a day. That's 300 milligrams TID without any side effects or problems. So she was able to get up to a nice, reasonable dose. She started doing online cognitive behavioral therapy and mindfulness practice to minimize her fears around the students aggravating her pain symptoms. And it was used to help her develop coping strategies. So non-opioid medications, and I'm going to kind of start off with this pre-test question number 6. So we and Janie decided to try the gabapentin to manage her postherpetic neuralgia. Which one of the following medications should we avoid while prescribing gabapentin? A, alprazolam, B, acetaminophen, C, lidocaine patches, or D, Celebrex. So this slide is a little bit busy as well. I'm going to kind of touch base on a few things. These are pharmacological approaches to the treatment of chronic pain. And I think we all know a lot about acetaminophen and non-steroidal anti-inflammatories, so I'm again not going to spend a whole lot of time on that. But really what we want to be careful of or cautious of is the contraindications and the adverse events related to these drugs. Tylenol, we see this severe hepatic function alterations, so we want to be checking liver function if a patient is taking significant amounts of acetaminophen over time. Some patients have come into my office and said, yeah, I took 5 of those because my pain was so bad. I go, oh, but your liver's probably not going to be functioning too well, so we need to slow that down and find a different alternative to them. So we want to really kind of take a look at the hepatic and renal impairment that is involved with these two drugs. And then adverse events such as GI upset, or like I spoke about, hepatotoxicity, so liver function abnormalities. And then with the NSAIDs, we're looking at GI upset, GI bleeding, renal impairment, hypertension. It's something we don't think about often in patients that are taking NSAIDs, but blood pressure starts to rise, and we're trying to manage that and trying to manage their pain at the same time. GI ulcerations, and then cardiovascular events. What drugs to avoid? In acetaminophen, of course, alcohol, phentoin, and Coumadin. And then on the other side, ACE inhibitors, anticoagulants, antiplatelets, corticosteroids, diuretics, lithium, and serotogenic drugs. What are some topical agents that we can use? And I'm going to focus on one of them here, but I'm going to read down the list here. Diflocanac, methanol, capsaicin, and lidocaine. And some of you may be familiar with Qutenza, which is a high-dose capsaicin application for patients with diabetic neuropathy. This has come around quite a bit now as well as an updated treatment. I think it's probably been about 3 years now where it's kind of really hit the market again. But capsaicin being utilized for the treatment of severe diabetic neuropathy pain. So it gives us another tool in that toolbox. But these topical agents can be utilized to help alleviate some of these pain symptoms. Of course, the diflocanac, we're talking something more along the osteoarthritis and musculoskeletal conditions. What are the advantages of these? You can read down these, and the disadvantage is really the erratic local absorption. You got to get them to absorb. That's the biggest thing. So, corticosteroids. I use corticosteroids quite a bit. Especially in the acute phases of patients calling into the office saying, my pain is exacerbated, and I need to do something quick. What do I do? Corticosteroids can be used if used safely. We obviously want to try to avoid those in diabetes and things where elevated blood sugar is going to occur, especially if it's somebody that's kind of on the edge of diabetes or pre-diabetic, and you can try to avoid these. I think you can get away with a very short course of it, but longer courses of corticosteroids might put you in a position where you're now treating their diabetes as well. Weight gain, patients don't like that, so if you give them a corticosteroid and they gain 10 pounds, they're going to be back in your office pretty upset with you. I like to tell them up in advance, look, this may be transient, just the medication you're going to take it, that weight will come back off. It's just a part of the medication. And mood changes, are these people that become a little bit excited, or do they become agitated on the steroids? So we have to just kind of watch those. Osteoporosis over the long term, our rheumatoid arthritis patients, if they're prescribed these medications on a regular basis and they're taking 5 or 10 milligrams of prednisone a day, every single day, do we have to start having concerns about osteoporosis creeping in? Are we doing our DEXA scans every 2 years or every 2 to 5 years, whatever is suitable for the patient? So are we doing these things to make sure that we're protecting the patient? We also have the use of muscle relaxants, and I like to use these in more of an acute pain process standpoint. They do come with some risk, and it's important to understand those risks, and that's probably what I'm going to focus on here. Sedation is probably the biggest risk. You get these patients, you put on 5 milligrams of Flexeril, and they sleep for 2 days. I don't know if anyone's had that, but I have, and so it's something to be very aware of, that muscle relaxants can cause people to be very sleepy. So it's something to look at. Dizziness, headaches, blurred vision, and dependency. I'm not sure that I've had a whole lot of dependency issues with muscle relaxants.
It's usually in combination.
Yeah, I think Soma, if you remember Soma.
Yes.
Yeah, I think Soma was a drug, if anyone's used it. I don't know, I see a couple of people shaking their head, but I used to use Soma in the past, but it was a drug that I felt like patients maybe had some dependency issues with. But I don't even...
It's a little pink pill. I can recall it.
Yeah.
It's distinctly in the pharmacy, and it always comes in combinations, opioid, Soma, benzo. That was our red flag.
Yeah. So Soma was one of those drugs that I think was probably, if dependency was a concern, it was one of the ones I probably was most concerned about. Muscle relaxants like cyclobenzapine, baclofen, and thiazidine are good options for the treatment of muscular type pain. Oh, antidepressants. Yes. Well, these are good options. I'm not going to read down the list of them, But I do think duloxetine is probably the one that's probably most commonly used, Cymbalta by the other name. But this is a good drug that kind of has a good combo effect for both depression and anxiety, plus pain relieving properties. So it is a nice drug that we can use. It has the greatest benefit in neuropathic and nociplastic pain symptoms. There's some evidence for the benefit of chronic musculoskeletal pain. The evidence isn't overwhelming, but it's there. It has analgesic effect, is independent of antidepressant activity. Usually onset generally takes 2 to 3 weeks, and this is something that I encourage you to tell all your patients, that if we start you on this medication, you're not going to see an immediate result. We have to stick with it. We have to stay with it. As long as you're not having a side effect or an adverse event from it, we have to give it its time to work. Let's reevaluate this in 4 weeks. Let's reevaluate this in 6 weeks. Let's see where we are. The tricyclic antagonists, those are listed here, like amitriptyline and nortriptyline. Those are used commonly as well. Safety considerations, I think I talked about this, but we see anticholinergic effects with the TCAs. So we have to be careful of constipation, drowsiness, dry mouth, those type of symptoms that patients are going to be experiencing. Mine happens to be due to the lights today, so sorry if I keep taking these drinks here, but thank you. Weight gain, obviously patients don't like the weight gain, so if they see any type of weight gain, that's going to be a problem for them, and they're likely going to end up back in the office with you talking about those things. On the SNRIs, suicidal ideations and behaviors, I always like to get the opinion of our colleagues in the psychological community, to help us with some of these. Cymbalta I'll prescribe, but I think beyond that, I start to get a little bit worried about those things, and really we'll talk with one of my colleagues in the psychology department to help me with what might be best for the patient. Interactions with the antidepressants, MAOIs, dopamine 2 antagonists, antiplatelets, anticoagulants, QT interval, prolonging drugs, so we have to be careful about that. Patients' EKG changes may occur, and CNS depressants. Those are all listed there, and the interaction and severity of the interaction is also listed there. Anticonvulsants, and I think the most popular we're going to talk about right now is going to be the gabapentin and the Lyrica. Those two are the drugs that we use most commonly. And they're really essential drugs and essential drugs for neuropathic type of pain. There is some evidence that they can treat chronic nociceptive, but it's more geared towards your chronic chronic pain, chronic neuropathic pain issues. They work by producing analgesia, by reducing neural hyperexcitability through several proposed mechanisms, and you can see those all listed here. For the sake of time, I'm not going to read those out to you here, but you do have access to those slides. But they all do have their role in the treatment of chronic neuropathic pain. So what are the dosing considerations? Well, again, I think one of the things with gabapentin, one of the things with Lyrica is you want to take it slow and go slow. You don't want to just dose them high dosing right away. You want to be able to observe for side effects such as swelling with Lyrica. Gabapentin is sleepiness. Patients become very sleepy with gabapentin. And a lot of it has to do with the reduction in the transmission of neurofunction. So we're slowing that down, like in seizure and epilepsy, we're slowing down those signals being sent to the brain. We're doing the same thing here. So we have to be cautious of that. Typically, I'll start at 300 milligrams a day, 1 week, 300 milligrams twice a day, third week, 300 milligrams 3 times a day. Let them stay on that dosage for a period of time and then readjust from there. Again, it may take 8 to 12 weeks for full effectiveness of these drugs. So we have to prepare our patients for that. We have to make sure our patients understand that this may take some time for these type of drugs to work. Topamate, that's Topamax. That's, we see that a lot in headache usage, right? Chronic headaches, chronic migraines, things like that. Very successful drug for the treatment of those. Our neurology colleagues use it quite a bit, and I do feel most comfortable with them using it, more so than I do sometimes prescribing it myself. All right.
All right.
I think that's it. So let's, I think we're moving on to so the post-test questions. So now we're going to get some answers to these. So like I said earlier, don't feel badly if you get it wrong. It's not going to have any effect on you. And honestly, these are important questions to be answered. So in 2021, opioids of any type were associated with greater than 80,000 overdose deaths in the United States. What type of opioid accounts for the majority of the opioid-related overdose deaths in the United States? A, heroin. B, natural opioids such as morphine and codeine. C, semi-synthetic opioids such as oxycodone and hydromorphone. Or D, synthetic opioids such as tramadol and fentanyl. Go ahead and write that down on your paper now. I like the game show music. There we go.
Much better.
Yeah. And if you chose D, you were right. So that's great. What happened there? Okay. In 2021, synthetic opioids such as tramadol and fentanyl accounted for the majority of overall opioid-related overdose deaths in the United States. This was followed by natural and then semi-synthetic opioids, and then heroin being the last, right? So that goes to what I said earlier in the lecture today. You would think, based on what we see on TV and what we hear in our communities, that heroin is the biggest problem for us, right? And it's not. And so we have to be cognitive of those things there. All right, post question 2. Which of the following conditions is an example of nociceptive pain? A, complex regional pain syndrome. B, fibromyalgia. C, osteoarthritis. Or D, trigeminal neuralgia. Nope. No, I just gave you all the answer. There you go. That one's on me. Good job, guys. Osteoarthritis, right? Because as we talked about, that's going to be your more arthritic or joint type pain that's going to be considered nociceptive. In addition to the physical assessment, what should we include in Jane's initial pain assessment? A, functional impact of pain. B, PDMP history. C, rapid mood screener. Or D, urine drug screen. Okay, I'm not touching the button now. Trigger happy.
Click.
Great job. Wow. I didn't give the answer on that one, and I think majority of the room got it right, so that's great. All right. And test question number 4. A multimodal approach of pain treatment is A, an opioid-free approach. B, in line with the biopsychosocial model of pain management. C, only necessary for patients with moderate to severe pain. Or D, not recommended by the Department of Health and Human Services. Well, it looks pretty good on both the pre and post tests. Great job, guys. Post-test question number 5. What is true about cognitive behavioral therapy for pain management? A, it falls under the umbrella of complementary alternative medicine for pain. B, it is only effective if the patients are motivated and put in effort during the sessions. C, it is the least evidence-based non-pharmacological approach. Or D, it is the most cost-effective option for most patients. Great job. Excellent. It is B. It is only effective if patients are motivated. Patients have to be motivated to do this type of treatment. So great job. Question number 6. We and Janie decide to try gabapentin to manage her post-herpetic neuralgia. Which of the following medications should you tell her to avoid with the usage of gabapentin? A, alprazolam, B, acetaminophen, C, lidocaine patches, or D, Celebrex? Great job. Oh, that's fantastic. Excellent. It was A, alprazolam. So good job.
Okay.
Okay, so are we taking a 10-minute, were we
If we
doing a
do,
break in
yeah,
between here for 10 minutes?
We have 50 minutes left total.
Oh, geez. Okay, well then sorry, I went a little too long there. My apologies. All right, so we're going to go ahead and bring up the next presenter. Come on up,
I'll let
Megan.
you review the questions that came in.
Okay, thanks.
For at the end.
Appreciate it.
To start with. And if you need to stretch, get up, please know that obviously is there. Drinks in the back if you need them. We'll kind of move through this next part a little quickly and get the major highlights, but please, the slide deck is available for review as well for each of you. So we're going to start at risk assessment, and Dr. Wells did a great job of thinking about history and assessment of all of the patients. But we need to remember that this really is a challenge because we're being asked to gather a lot of information, and most primary care visits are very short. And so we're being asked to really assess something very quickly. And so using a lot of the tools from the exam, the diagnostic screening, the PDMP, patient history, can help us really have that discussion about risk. We do need to screen all patients. I think, Dr. Wells, you gave an excellent example of when you got duped by a patient. I was easily duped many times in the pharmacy by patients bringing prescriptions in, so I know it happens frequently. But thinking about screening all patients, also understanding that higher risk doesn't equal substance use disorder. Just because someone's on a benzo or a muscle relaxer or some other thing doesn't mean that they may have substance use disorder, but it does need to be screened for. And not denying patients care, even if that diagnosis is there, because those patients do suffer from pain as well. And this might be when we want to look to our mental health colleagues for help. Stigma is always a big area in this arena, and making sure that we're using terminology to not stigmatize our patients, probably more than they already are. Making sure that we're looking at different terminology. So your urine screen was positive for or negative for. It isn't a dirty urine screen. Making sure that we're thinking about different terms and misuse, diversion, opioid use disorder, and using those terms appropriately. I'm always thinking about pill counts, especially when patients say they lost medication, stolen medication. My purse was stolen, it got flushed down the toilet, my kid knocked it over, all of the different things that happen. Are they diverting, right? We had a great example today of where the medication was being diverted. And typically we pick these up on urine drug screens when things are negative, and it's very hard to explain why you don't have it in your system at all. And then opioid use disorder. Is this seeking out additional medications? Is this larger quantities, longer duration, continuing beyond what we might expect from a sprained ankle or some sort of surgery, that it's extending beyond what it should be. There are lots of different risk assessment tools to consider. Some of these are when you're initiating treatment. Some of them might be more long-term maintenance when you're thinking about how to use each of these different tools in the patients. Using these tools is not done alone. You should think about your interview with the patient. That's where you're going to maybe be able to uncover some information, looking at family history, personal history of substance misuse. And this is where your PDMP can be very important to sort of review where the patient has been. Lots of things can be picked up from that. Is there other trauma that might be going on as well? And in thinking about that, are people being asked to get medications? One of the things that I have discovered as a pharmacist too, that we're seeing now too, is people are using their pets to get pain medications and things like that. So as a pharmacist, we're also screening all pain medications that come in for animals as well. And so just really doing risk assessments in whatever arena that you're functioning in. Dr. Wells went over all of these different factors to consider, so we won't spend too much time here, but thinking about all of the substances, social, psychological factors that would go into this risk assessment, and then the protective factors as well that might help us consider some of this. So do they have family that is around to help and involvement, positive relationships, community engagement, things of this sort. Reviewing the medical record. Are there frequent communications? Is this a patient that you know calls in, follows up, comes to appointments? What do the medication requests look like? What are their most recent visits been for? Do they have any encounters with outside facilities? Very impressive now when a lot of the electronic medical records and being able to sometimes pull that information all together for us. But this does take time then outside of maybe your 15-minute appointment to do a lot of this review. The PDMPs, I don't want to spend a great deal of time here. I'm hoping that each of you has access to your state PDMP and are looking through those prior to prescribing medications. It's very interesting to see in each state how very different the rules and regulations of who has access, the types of information, and then how many states around your state talk to each other. I think especially in this area where people can travel very easily between states, it's very important to think about. I like to use them to make sure that I know what a patient's receiving, because sometimes they're seeing you for something, but they also have a mental health provider and they have this person over here, and they might use different pharmacies. Sometimes people get locked into one pharmacy for something, and then they have to use the specialty pharmacy for something else. And so this can sometimes bring information together to be very helpful. So using them, really, it's important. They're only good if you use them, right? It's nice to have them there, but before we prescribe, and so not afterwards and calling back and saying, oh yeah, now I've looked in it. So there's a link here in the slides if you do need information about different states, and really not dismissing patients from care just based on what you find in there. This is an opening discussion to start with the patient on how to think about what we might be using as a treatment option. So let's use this as a place to get that information. Now, I did appreciate when we talked about substance of abuse. Now with cannabis, I think that could be an entirely whole day discussion about cannabis, but definitely something to engage in discussion around, because patients may have trialed that for pain. And so you might need to consider before prescribing that in your risk assessment as well of what people are using based on that. So we're going to switch cases to Warren now. And this is a 67-year-old man. He has some past diagnoses here, multiple joint arthritis and chronic pain that we're really going to be focusing on. He's not a candidate for additional joint replacement surgeries at this time. He's had complicated infections and things of that sort, so he's really not a candidate. History of chronic kidney disease, and this is really thought to have been prior NSAID use that has led to this. He's had some mildly abnormal LFTs. So he's had chronic pain in multiple joints despite participation in PT. OTC medications haven't been effective. He's been advised to avoid the NSAIDs because of the kidney concerns. Tried gabapentin, had a bad reaction. Tried duloxetine, had nausea. Social history is here as well. Father had likely alcohol use disorder. Probably like many of the patients that we've seen, they've tried all the things and now we're to the next step. And so here is the risk assessment that has been completed, and some things are circled that we might want to kind of review a little bit higher. How often do you feel bored? How often have you worried about being left alone? Close friends that had problem with drugs and alcohol, had to borrow pain medications from friends that, some of those things crept a little higher. I might think about mental health a little bit if some of those concerns about being left alone and things of that sort, but low risk and the PDMP and the urine drug screen were both appropriate for this patient. This seems to be a very ideal patient. So let's kind of run through some of the opioid approaches that we might consider. So pretest 7, keeping in mind his diagnosis of hemochromatosis and multiple joint arthritis, as well as his current blood work showing mildly abnormal LFTs and creatinine level is elevated, which agent would be most appropriate for Warren? Just a minute here. Is it codeine tablet ER, fentanyl patch, morphine tablet IR, or the oxycodone tablet IR? Okay, we'll come back to that. Thinking about opioid use, we do have to think about, is it chronic or is it an acute? We might think in acute where this is severe pain that's not responsive to other options. In chronic pain, this is severe enough pain to require opioid analgesia, where other treatments may have been inadequate. And we might think about extended release formulations as well. And we'll talk a little bit about transitioning from the immediate release to the more extended release type of products. Very briefly, opioids work as agonists on the mu opioid receptors. We obviously have naturally occurring opioids. We have synthetics, semi-synthetics. We've talked a little bit about those already. And so we're going to really kind of glance over this. But really, I think our important things to know are adverse effects of respiratory depression, sedation, and that GI concerns, and thinking about bowel regimens for patients that we do consider opioids for as well. We have our choice of various combinations, immediate release, and these really are that sort of real quick peak of medications, the delayed release, which allow a little bit of time to pass before they are releasing, and then our extended release, and there are tons of various products with different extended release formulations that really are over the extended time, which allows for less gaps, and so you're less peaking and troughing, and people are saying it's wearing off. And these can't be crushed or chewed because it really affects the entire release mechanism of the medication. So here are some of the considerations for the various types of routes of administration. It's very interesting now thinking about some of the sublingual tablets and how making sure we're educating patients on whether those can be influenced by foods and liquids. And sometimes if you touch them, when you pull them out, then they sort of start dissolving. And so there's lots of different things about this. And then transdermal, which might be better for some patients who have maybe swallowing problems or dexterity problems with opening pill bottles and things of that sort. So lots of different routes to consider. Also important to think about abuse deterrent formulations. Is there particular physical or chemical barriers that prevent crushing, grating, snorting, all of those things? Do you add the antagonist to it? So is this a product that contains naloxone as well, so that if it does get crushed or things of that sort, that it does divert that? Do you add nasal irritants to avert something? And so all of these different types of aversion, types of areas we would consider in patients where we might think about if there is diversion concerns. And so in our risk assessment, that's important to consider. Okay, so here is some of the various opioid products and thinking about where they are working within the system. So we have our agonists, our mixed acting partial opioid agonists, and then our antagonists, which are going to be maybe our rescue medications or use for those with substance use disorders. And then there are some opioids with some monoamine activity, and so these are going to lend themselves very well to some additional drug interactions and concerns as well. As a pharmacist, I am keen on all of my drug interactions. This is our bread and butter, and we're thinking about whether it's pharmacokinetic, so it's going to be interacting with other medications that they're on. And usually we think about our cytochromes, 3A4, 2D6, but not forgetting P-glycoprotein and UGT. And then also thinking about dynamic interactions. And this is where we talk about benzodiazepines. Are they on other anticholinergics, alcohol? Are they on opioid antagonists? And so really finding a pharmacist friend or having a good database that you can run some interaction checkers at times, especially with all of these new medications coming onto the market and keeping track of all these cytochromes and where their substrates can be a bit overwhelming. So here is some of the information on metabolism. Opioid agonists are largely metabolized by 2D6, as are the majority of other drugs that are used for any various disease states. 3A4 is largely responsible for buprenorphine, fentanyl, methadone. So when we think about inhibitors of 2D6, fluoxetine, bupropion, paroxetine, these can decrease analgesia effects of some medications, which may be prodrugs, and need to be metabolized through 2D6. So thinking about some of these interactions is really critical when prescribing particular medications. Here's just some basic comparisons between some of the more common opioid medications and what formulations they're available, and then some notes. Hydrocodone, one of the most important things is to think about hepatic dysfunction due to the Tylenol component within that. I also think this is very important to educate patients because they're also picking up that NyQuil, Dayquil, all those things over the counter when they get a cold that also have Tylenol in it that now is called acetaminophen. So patients get easily confused because they may not realize that all of these things are the same products. So really keeping in mind that additional Tylenol component with all of our combination products. Buprenorphine, we're going to touch on that a bit more too, now that some of the DEA regulations have been changed surrounding that. Here are our other opioids with some monoamine activity, and it's important to think about the use of these medications potentially with other things like duoxetine or any of your antidepressants which have serotonergic properties, because you are adding potentially to that serotonergic load and increasing risk of serotonin syndrome in these particular patients. Buprenorphine, this is our partial agonist that has that ceiling effect, really limiting respiratory depression, euphoria, that drug-seeking effect for this. Really, this has been preferred in substance use disorder patients, but there is a great use of it in pain as well. Possibly for patients with opioid-induced hyperarthralgia, patients with concurrent neuropathic pain. It does have other formulations, does come with a naloxone component if you're using the sublingual tablets. So there is a lot of things here. There does need to be consideration for dosing and making sure potentially that we're getting patients on it and not throwing patients into withdrawal with giving it, because it is the partial agonist. So if someone's on a full agonist, where our history becomes very important in our patients. Side effects. Constipation probably is the one that I think we really have to be concerned about, in addition to our respiratory depression, cognitive impairment, drowsiness, driving things. But thinking that we're making sure patients are aware of that, and that some of the other ones may wax and wane over time. People develop tolerance to things. Constipation, they're not going to develop tolerance to that. Respiratory depression, we're going to talk a lot about naloxone today, but making sure that you are looking at all of that risk factors. Do they have sleep apnea? Are they on other medications, which can be CNS depressants? And making sure that we're sort of looking at that entire load together. And then looking at our long-term hormonal changes that can result in some reduced libido, mood changes, weight gain as well. With chronic opioid use, there can be physical dependence that can occur, and physical dependence does not equal addiction or substance use disorder. This then can lead to withdrawal in patients who might miss a dose, or it's now Friday night and the pharmacy closed before they got to pick it up, or something of this happens. So keeping in mind that you can develop a physical dependence to these. And the risk of developing that substance use disorder or addiction to this really varies from person to person. And a lot of history and genetics and psychological and environmental factors have to be weighed for that as well. So here are some of the warnings and precautions, and I think we've done a great job today thus far of kind of going through these potential warnings and precautions. True allergies to opioids or receiving active treatment with naltrexone, psychiatric instability, high suicide risk. Those are probably some of the ones we haven't mentioned too much today, but the others we've done. Okay, so co-prescription considerations, and I know there was a couple of questions that we'll get to on this, but really thinking about the risk of respiratory depression and overdose, even with buprenorphine. We've done a lot of push to talk about opioids, and I think the benzodiazepines have kind of come along for the ride, but maybe haven't been the focus, but really making sure that you understand how they're using those other products as well. A retrospective analysis has found relative increases in opioid-related overdose, and those increased risks are here for you to think about how that increases the risk. And so really educating patients on this. And also thinking about our Z drugs. So now we have somebody on something for sleep or some of those other things that maybe we're not prescribing, but somewhere along the line they're getting. Also important, renal, hepatic, looking at those, because there are going to be particular medications that you're going to avoid based on abnormalities in the liver or the kidney, and using lower doses or extended interval dosing might be how you have to go. Don't forget about patients with opioid use disorder. Those patients get into car accidents, have back pain, do all the same things, so they may need acute pain treatment. And they want to make sure that we give access to opioids when it's indicated with close monitoring, but also doing it in a patient-centered approach. Some patients with opioid use disorder are going to say, absolutely not. And they're going to look for alternative strategies for that. If you're using buprenorphine and methadone for the opioid use disorder, they're probably going to need more than once daily dosing if they have some sort of pain. And most of the time they're dosed once daily for opioid use disorder. So you might have to do some changes within that dosing parameters. Considering respiratory depression, I wanted to make sure that you at least had a scale if you were trying to think about other disease states or other conditions, and how many other things that should be considered if you're thinking about the additive effects of respiratory depression for this. And so looking at other medications, looking at other disease states that they may have as well. So when we think about initiating treatment with opioids and we're getting ready to e-prescribe or write that first script, I think the CDC guidelines are an excellent resource. Know your practice setting, understanding the ability to have that patient come in, have you had risks and benefits, you've established your expectations and goals, and you've evaluated opioid use previously. Someone might be opioid tolerant, and this can happen within a week of daily administration, and I've included the doses here so that you could see what that might look like. And so if someone has been on this for a week and they've been taking it, they may be tolerant, and so you may need to choose other medications. And so here are some of the common starting doses, and keeping in mind that some preparations are not suitable for all patients. You don't want to give the patient who this is their first time a fentanyl patch or some long-acting product. You really want to make sure that you're thinking about the patient, starting with some short-acting formulations for those who might be opioid naive. These contain smaller overall milligrams of opioid, and you save the longer acting and for those that might be more opioid tolerant. Begin with the lowest effective dose and limited quantity. And so really thinking about how many tablets does this patient need? And it's been a vast shift over the last 10 to 20 years in wisdom teeth removals. It used to be, here's 20, 30 Percocets, and now it's like, here's 5. And so really thinking about the lowest quantity that someone might need for those things. Okay, let's think about safety education. This is an area where probably gets gleamed over. I know when I go into offices or see things that by this point in the appointment, there's not much time left. So here's the prescription. Hopefully your pharmacist will talk to you about it. But thinking about the risk-benefit profile, thinking about safety at home. Do they have young children in the home? Do they have grandkids that come over? Making sure you're thinking about all that safety in the home. Lowest dose, limited quantity, short-acting, and then the co-prescription of naloxone, and thinking about who is right for that. I think all patients are right for that co-prescription of naloxone. It just makes it easier. This is our practice. Everybody gets a prescription of naloxone. Set SMART goals with the patient, and SMART goals are goals that are reasonably right for that particular patient. Monitoring plan, and we're going to talk about the patient prescriber agreement. Harm reduction probably spans not only pain, but also substance use disorder, and that's a little bit where we're headed, but thinking about making sure that the patient understands the proper use of the opioid medication. We need to think about our safeguarding, our monitoring, adverse effects, and there's no universal right way to reduce the harm with opioids. You really need to think about the patient and the community within you prescribe to do this. And all of this, if we do it with every patient, it becomes non-judgmental because it's just the policy of the clinic that we're going to do this with every patient every time. And it makes it much easier. So you could consider a patient prescriber agreement, and this is really going to just set forth the expectations of being managed within the context of pain. And you don't want to use punitive language or measures and say, if you come in and you're positive for something else in your urine drug screen, you're out. Like, we dismiss you from the clinic. But you want to make sure that you lay out the expectations up front with the patient, keeping in mind literacy levels of patients as well. And really, you should thinking about this before your opioid treatment if you're considering that pathway and laying out these expectations. And I think this little example here is really nice. It kind of includes some of the goals of the patient and some of the other options as well. So here's just some of the big items that might be included in here, thinking about avoiding other illicit substances, side effects, storing safely, not taking them more than prescribed, remaining adherent with the urine drug screens, prescription follow-up, and sort of what are the ramifications if some of these things are missed along the way. We're thinking about goals and setting those, and ultimately what a termination of a patient might look like. What could that look like? We're discussing all the risks, benefits, if a taper would become necessary, other treatment modalities, naloxone, follow-up protocols, lost and stolen medication. Do you get a one-time pass for that sort of event? Because inevitably it does happen. People leave it in hotel rooms or on vacation or things of that sort. But, if this is a repeated thing, it's better to address it up front so that everybody knows the rules prior to starting a treatment. Looking at monitoring and required visits, there may be state requirements for drug screening or unscheduled testing. And so making those upfront and patients aware that you may be called to come in for a urine drug screen and you have 2 days to present for that, or whatever sort of regulations you want to put around that. How will you handle telehealth visits versus in-person requirements? How often does the patient need to come in? What about cancellations, or if you come late for your appointment? So there's a lot of things to consider within your own treatment plan within your clinic. Making sure patients know where to store and dispose of medication. And this is a question we get all the time in the pharmacy about take back days. Does your police station have somewhere that they can drop medication? Can you buy those bags where it's a send back? All of those things are important. Getting them out of the house as soon as you're not using them anymore is really key, and not storing things because you might go back on it, or your friend or somebody might need it later in life. When you travel with opioids, I think this has now become a very interesting thing, and making sure that you're in your original bottle, that you have a note if you need it from the healthcare provider. Put it in your carry-on, put it in your pocket somewhere that isn't going to get lost when your luggage gets lost. So all of those things are important. Communicating tips for follow-up visits. What are you as a provider, what are your expectations for urine drug screening? And what do the patients expect? And when something may not go as planned and it's positive for something else, how are you going to discuss that with the patient? Talking to your patient about when to call the provider. When do you call me? Making sure that we talk about what happens if you miss a dose, what happens if you have a serious adverse effect, when new pain or worsening pain, or if there has been an overdose event. All of those things are laid out for when to call the provider. Here are some of the common adverse effects that patients will likely call about, and some of the education points that we can think about. Constipation. This is probably a big one I think about all the time. It can occur with any opioid. So it can become severe, right? This can become life-threatening if it's unmanaged. So getting ahead of it rather than behind it. Don't wait for the constipation to develop. Let's get ahead of it so that we don't have to do any severe treatments for that. Mild itching may be common, but if it looks like it's hives, rash, this could be a hypersensitivity reaction that we want to call the healthcare provider. Nausea, vomiting, important. Sedation, confusion, heavy machinery, making sure that we're educating patients about operating cars, lawnmowers, being alone at home or things of that sort, thinking about all of that sedation and confusion, especially in patients that might be older in age or have decreased metabolism. We don't need fall risk as well. Overdose can be accidental or intentional, and it can go either way. And all opioids carry the risk of overdose. Definitely there are those that are at higher risk than those that might be less likely, but it can occur within minutes to hours of administration of the opioids. And if they're on a benzo and they took an opioid and they went out to dinner and now they're having a glass of wine or a muscle relaxant, something else, there definitely can be an additive effect. And so making sure that patients are aware that it doesn't just have to be an intentional overdose. And sometimes it's not the patient that you are educating on this, because they aren't going to be the ones to treat themselves potentially in an overdose. So this is where it's important to bring in that caregiver, family member, loved one, friend, thinking about, these are the signs and symptoms that you need to be looking for when your loved one is on an opioid. Respiratory depression. Do they have constricted pupils? They're hard to awaken. And they have extreme somnolence. And many of times the overdose deaths occur inside a home that we think about, well, if they would have had naloxone. And so this is why a naloxone prescription, probably with every opioid prescription, just makes it easier for everyone. And many times there is potential for life-saving actions had everything been in place in the right time. So naloxone, this is an antagonist, so it's going to block the effects of that opioid and reverse that opioid overdose, including respiratory depression. And so it just very conveniently is our antidote. So this is not an opioid use disorder treatment, right? This is just reverses opioid overdose. It's not a scheduled drug. It can be very safe in any population, children, babies, pregnant people, older person, acts quickly. We're going to talk very briefly about some of the different mechanisms that it can be given. Sometimes, remember, you do have to give a second dose. You can repeat while you're waiting for EMS to arrive, and so it's important to educate our family members on this. If the patient's not responding, maybe it's not an opioid overdose, or there may be something else going on. And the shelf life is 36 months, so you don't need a prescription potentially every time if they have one, and sometimes you might ask them to bring it just so that you can verify that they do have that as well. Okay, there are different formulations for this, and with naloxone going over the counter, I think there was a great thought that, oh, this is great, now everyone can get it. Well, now it has a cost, whereas before, if your insurance might have been paying for it, it might have been free. And so thinking about, is it available elsewhere? Are there places where patients can get it at a reduced cost? They can still get it paid potentially through their insurance. And so thinking about making sure that patients have access and it's not too costly for them. And you also want to make sure they have it. You don't want to wait till an overdose happens and someone's running into a community pharmacy to do this. There are nasal sprays. These are, going to be very easy to use versus an IM injection, or the easiest really might be the auto injector. It's simple to use, no training, but they're going to vary in cost, and it's going to depend on who's administering it to the particular patient. The IM injection is going to be probably the most challenging. Someone's going to have to draw it up and know how to do that correctly in an emergency. Adverse effects, really the major adverse effect is that it can cause opioid withdrawal for the patient, which can be pretty miserable, but if it's life-saving, then it would be important to do. So opioid withdrawal is not life-threatening. Contacting EMS either way, even if the person responds to naloxone, is going to be very important because it doesn't have a long effect. There have been some reports of acute pulmonary edema with this. So I think everybody should get naloxone. We're not going to read through all of these different things, but if you're thinking about who you might consider it for here, but for everyone who gets a prescription. So here are just some key education points. We're not going to read through all of these, but keeping in mind that, there are Good Samaritan laws, and so treating the patient is going to be really important no matter the situation. Don't store the naloxone with the opioids. If you're locking the opioids up, you want to have that naloxone ready to use if you need it, but making sure that it is available. Okay, maintaining opioid therapy. Here, we're going to be looking at follow-up visits. We're assessing the patient to look at those goals that were set forth at those initial visits. Are they meeting those goals? Are they seeing some functional improvement? Is there changes in their underlying pain? Are there any concerns? Are they having side effects? Is there a tolerance? Are we noticing any diversion? Here are some suggested timelines for follow-up visits, and these may change, depend on your patient's risk level, but you're going to be talking about side effects, functional improvements, and then, how long do we need to continue this potential opioid treatment? And obviously, the higher the risk, probably the more frequently you're going to be engaging with this patient. So urine drug screens and pill counts. Screening should take place at baseline. I think Dr. Wells gave us a great example of getting it before you get that, before medication initiation, so you know what's there. Whenever there might be suspicion, or you may just set up a guideline that everybody on opioids is going to get urine drug screens at certain points. And clinical judgment can take that into account, and then consideration of if it's going to be random versus scheduled testing. Making sure we're using the right terminology. We're not confronting patients, right? Saying your urine drug screen came back for cannabis. I was unaware you're using cannabis. Can you tell me a little bit more about that? And so making sure that you're having those discussions so that you can think about next steps based on the results and expectations of the clinic and the patient. Pill counts. Well, pill counts are pill counts. Patients, depending on when you call them in and how quickly they get there, sometimes they can be a little bit fudged, but they do allow us to see if the correct amount is being taken. If you have a policy that says, you do need to bring that in within the day, and then they have none, it's probably going to be hard to scramble to find some, but it is important to consider that. And sometimes it might just be every time you come, you're going to bring all your medications with you, just so that we can sort of see what kind of things are happening. Medication adjustments. Okay, Warren was prescribed the oxycodone IR, 10 milligrams every 4 hours. At the 4-week follow-up, he's tolerating the medication, but is experiencing significant periods of increased pain between doses. His risk assessment score, if you'll recall, was not concerning. So what should we as a team do to address this? We can increase the oxycodone. We can switch to the ER at a lower dose, switch to the ER at the same dose, or switch to the ER at a higher dose. And we're going to come back to this at the end. So this kind of gives it away. After you switch to the ER, but I didn't tell you if it was lower, higher, or the same. He calls your office to let you know that he has 11 extra pills left of the IR. And what do you instruct him to do with that? Flush them down the toilet, give them to a friend, go to the police station, or keep them in a locked location in case we need to go back to that because pain flares up. Follow-up. We're going to follow up at 1 to 4 weeks after initiation or any change in drug therapy. And then we're really looking for all of those different effects of the medication, side effects, how is their mood, what kind is their behavior, what do their activities look like, and we'll think about other options along the way if needed. So here are the 5 A's of opioid therapy monitoring, and I'm going to leave those here for you to read. And again, we talked about monitoring adverse effects and how to manage those. Some dosing pearls, very quickly, starting with the IR formulation can be helpful in establishing response and tolerance, and then converting between IR and ER at equal analgesic doses if it's the same opioid. And then if you're converting to a new one, then you would reduce the dose if you're converting between IR and ER products. You may think about increasing the dose when the pain isn't sufficiently managed. You want to make sure that you've given it a time to work, and then think about switching that if the patient isn't able to meet their goals. And you want to think about switching if they're receiving around-the-clock short-acting. So maybe they're setting their alarm so that they're waking up every 4 hours at night. If there's a new event or new condition that you would consider. So here's a little bit of information on how to increase the dose. And I'm going to try to keep us moving as we get very close to the noon hour here. Modifying regimens. When there is some patient-specific factors, you might think about switching between agents. And here are some of the different agents and specific opioid receptors by which they are partial or full or an antagonist, and you might consider some switching of agents to different mechanisms if a patient's not responding. Okay, so here's just an algorithm very quickly of how to think about rotation between opioids. And some of the conversion factors for your morphine milligram equivalents, and making sure that you're using these to make sure you're converting between products appropriately. And this probably could be a whole day lecture. If you have a patient who's had no improvement, or they've seen improvement now with a non-opioid, or they're having intolerable side effects, some rationale for you might considering tapering. These would all be rationales. And at the end of the day, benefits, physical dependence, addiction, long-term side effects are probably also rationale for considering that. So pace of the taper is going to be individualized. Here are some of the various options. Probably the slow tapers for those that have been on it for a very long time or a chronic type of the pain. And it's always going to be patient-centric, where you're utilizing patient information in addition to that as well. So here are some of the considerations of how to do this. Many times, if they've been on a chronic opioid for a very long time, this is probably something where we're probably thinking about asking a specialist too, just to make sure that we're not creating additional withdrawal symptoms or potential withdrawal of the medication. So if they would have withdrawal, it can be across the board of the timing and how long it may last and the types of symptoms that you might see. Very, very briefly, we're going to hit opioid use disorder in our last few minutes. So I'm going to roll through how comfortable we all are in managing this so that we can keep moving. We'll scroll through addiction model, but think about factors for developing substance use disorder. Think about what kind of environment they live in. What is the social aspect? What are their peers? What is their childhood psychological issues? Genetics, does it run in the family? And some of those items. Stigma, we talked about this very briefly as we started. Harm reduction as well, making sure that we're choosing the right terminology and thinking about treating these patients as we would any others. Thinking about screening, brief interventions, and referral. This is a great tool that we've been using in our emergency rooms and trying to determine risk and then where we need to consider a treatment modality for the patient. So here are some of the types of screening and assessment tools. We're going to kind of pass through those too as we round out the hour. And then here are how you might consider treatment referrals for patients based on the level. Comprehensive care. This substance use disorder treatment could be a 3-day, 4-day, could be a whole week review. So thinking about behavioral, spiritual treatment, medication treatment, the gamut of things, and making sure it's a comprehensive treatment plan is very important. There is several different treatment approaches. There can be support groups, there can be behavioral, there's medications such as naltrexone, methadone, buprenorphine, a lot of different treatment options. Prescription exit strategies. Health and Human Services does not recommend abrupt reduction, right? We do need to taper those, thinking about treatment for OUD, and then not having acute withdrawal symptoms can be important. There's lots of things for opioid use disorder. We have long-term pharmacotherapy. This can be years to months to lifetime. And then there can be the importance of non-pharmacologic, where we're starting to establish treatment over time. So we won't discuss our options today because we're down to 2 minutes, but these are your considerations, and I'll hang around if there's questions on those. I think it is important to note, though, that the removal of the X waiver now allows for increased access to buprenorphine prescribing. Interesting, we're not seeing a ton more people pick up buprenorphine prescribing, but it is accessible now if people do not have their X waiver. But considering that counseling and psychotherapy is still a separate component and very much should go hand in hand with buprenorphine or naltrexone. We're going to kind of quickly just roll through these where I would have spent some time. But let's think about managing pain in opioid use disorder. This is going to be that multimodal approach, using some of the non-opioid analgesics, shared decision-making with your patients. If you do need to use opioids in someone with substance use disorder, lowest effective dose, small quantity, naloxone, regular urine drug screens, pill counts, all of the gamuts. And then referring to a pain or addiction specialist is going to be really important to make sure it's all managed very well. If there is a relapse, there are lots of different ways that you're going to notice that, but making sure that that patient then is reevaluated if they haven't been seeing a pain specialist as well. So let's quickly, in our last minute, vote on these last questions. So keeping in mind Warren, what would be our most best approach for treating Warren initially for his multiple joint arthritis? I'm going to kind of gave away these answers as Warren went on. Okay, this is the oxycodone tablet IR. So he was opioid naive. We're going to go with the IR product. Once we gave him the IR product, now he's going to have some pain between those doses. So we would address this by switching from the IR to the ER at the same total daily dose. And post test 9, after switching to ER, he calls your office to let you know he has extra. And we would go to the police department to have those disposed of. Most police departments will have those nice big blue boxes that you can drop them in. And which of the screening tools is scored differently based on gender? And I know this was on the slide, but I don't believe that we read it out loud. And this is going to be the ORT-OUD, is scored differently based on the gender. And which of the following is true? Patients must abstain from opioids for greater than 7 days prior to naltrexone initiation. And it's very important that they are, because you have the opportunity to put them into withdrawal if you give them naltrexone prior to being within opioid withdrawal. Okay, so I know we are over by a minute already to 12 o'clock, so I want to look to also to our esteemed colleagues who are running this. I don't want to miss anyone's lunch. Okay. Perfect.
Yeah, I'm going to let you guys do a few minutes for questions, because I'm sure there's a couple of really good ones there.
Do you want me to take them from the tablet? Is that fine?
Yeah,
Okay.
yeah.
All right. One of the first questions we have today is, do you have a sample of the patient prescriber agreement? I do believe there is one on the slides,
Yep.
but also if you see me afterwards, we can exchange emails, and I'll be happy to provide you with a sample copy that I have available, okay? More on social factors. This is a virtual question more about social factors. And social factors are important for a lot of reasons. And I think maybe the question is probably, are there additional social factors that we should be looking at? And honestly, you have to tailor that towards your practice and what you're looking for specifically in that patient. And those social factors should really come into play after a comprehensive evaluation of the patient is performed. So additional social factors can be obviously pulled from the patient as you're discussing and having a real conversation with them about their needs and their wants and desires for their actual treatment. So I think really to answer that question, it's something as the provider individually, I've come to tailor over time and really kind of included more and more of the social histories and social aspects of what they're dealing with into my physical evaluation of the patient. This is probably
thinking for opioid use disorder treatment as well, or thinking about people at risk for that. It's also thinking about their environment.
right.
They live with someone who may also be using
Exactly.
illicit medications or things of that sort. So thinking about, if I'm working on treatment with you, how do we fix some of the psychosocial factors? If we're sending you back to the same environment, it may not
Exactly.
go well.
What is the cost of naloxone? How do patients get naloxone for free? Is that still available? I know for a long time it was free of charge for patients, and I heard through your lecture that they've changed that now. And so what are your thoughts about that? Is there a cost? How much is the cost of that, if you know? And is there a way to still get it for free?
Over the counter, I want to say, if I've been into a community pharmacy, it can range, but I've seen like $50 or something, which is still very expensive for a patient to go in and purchase. Some insurances will cover it, but that does then require a prescription because you're going to the pharmacy to have that filled. Health departments may have it, depending on the state that you're in or the county that you're in. There are areas for that. And some hospitals do have programs upon discharge where it is provided as part of your care.
And you're not aware of any free programs that
Not free, just off the top of my head, no.
How long do you expect, I guess that's probably more a question for me, how long do you expect surgical teams to control postoperative pain? They often find that what's happening is that's being sent back to them fairly quickly. Yeah, that's a very good question. And really, in my experience, I typically will treat a patient up to 4 or 5 weeks. I start to get a concern if we're pushing past that point. But I also will then reach out to my family practice colleagues and say, hey, I'm running into a position now where I'm outside of the post-operative period of time, working collaboratively. What do we do as a next step? Do you want me to send this patient directly to pain management, or would you like me to send them back to you for a short period of time to make those decisions? So it's really a collaborative discussion at that point between colleagues about what the best approach for this will be next. Okay. What do you prescribe for constipation? Well, I typically use Colace. I mean, that's a first step. I have a protocol in place already that patients that are going on opioids go on a bowel regimen. That's something that I've instituted very early on in practice, something I still continue into practice today. And that's, Colace to start, Miralax to follow if we're not making any progress there.
Yeah, just a sort of a stepwise approach, but getting that, that Colace immediately. So it's like you take the first dose of opioids and you're already taking that Colace.
Great.
Yeah.
How successful has pill counts been for you? Well, it's a mixed bag. Honestly, if you do it right, it does have some quality to it. Patients got smart. I mean, well, I shouldn't say they got smart. They are smart. And patients that are trying to deceive you will do things that will ultimately be deceitful. So, they'll buy pills, they'll share pills, they'll do those different types of things. But our policy has always been you have 24 hours to get here. We call you at 9 o'clock in the morning. You should be here before the end of the day. That gives them very little option. But to answer the question, we have to use all the tools available to us in conjunction. And using those tools will help us identify those patients that may be deceiving us in some manner.
And those are patients then that you think about, okay, so if they are, then, is it movement to an opioid use? Is that the referral that's made is to mental health or an addiction specialist versus just dismissal from the program?
Yep. Another great question.
Time for one more.
Okay.
One more.
One more question.
One more question.
Okay. I think this is a good one that kind of hits home for everybody. How do you counsel patients about driving when using opioids for chronic pain management? It's a fantastic question. And, I think one of the things I'll tell my patients quite frequently is that you're at a liability no matter what because you're on the medication. However, we have a much better fight if you've been on it for a chronic period of time. If you've been stable on it, you haven't had a motor vehicle accident or you haven't had some kind of adverse effect to it, and we've been using it, there shouldn't be an issue in concerns of their driving. The DMV may think differently, but that is something that I tell them that I don't think there's a concern. Now, if we are in the process of switching doses, if we are in the process of making changes, there's a lot of caution used at that time. And I tell them that until we know that these medications are not going to affect you negatively, we need to go ahead and hold off on how you're driving or the frequency in which you're driving or the timing in which you're driving. So they're usually pretty receptive to that because they don't want their license taken away from them. And we certainly don't want them to be in an accident that can cause harm or damage to themselves or other people. So. And we document that. I think that's important too as well.
That's the most important part.
You have to document that conversation. Is exactly right. So,
yeah.
Thank you.
Thank you.
Thank you.
I think this was awesome for everybody.
Thank you.
That was it.
Before we break for lunch, I know that was a long one. Virtual people are going to get a break too. I just want to remind you of some important things. Don't forget about the handouts that you have to fill out and drop back at the desk. Also use the QR code. Welcome back, everyone. Hello to all the virtual people. I'm glad that everybody made it back from lunch. I hope it was enjoyable. So we have 2 more accredited educational sessions this afternoon. I'm going to make the same reminder I always do. Make sure you're using your iPads to participate in the polling questions. And don't forget about the survey that you can complete also. And remember, you can add questions in during the talk so that we'll get to them at the end. Right now, I'm really pleased to introduce to you our next speaker, Andy Woods, who is a professor and chair of the Department of Translational Science and Inpatient Practice at Wingate University School of Pharmacy in Wingate, North Carolina. He will be presenting Going for Gold in COPD, Optimizing Diagnosis and Management in Primary Care to Enhance Patient Outcomes.
Thank you very much, Tracy. Sounds good. Yeah, I can hear myself. We're golden. Get the slide advancer here. So Tracy, appreciate the introduction very much. And to whomever is in the room that had a hand in planning this and inviting me to speak, thank you to you. This is a passion of mine. I realize it's not a passion of most. So again, very appreciative. Title slide. Disclosures are listed here. You can read them just like I can. No bias whatsoever. I want to ensure that and make sure that you know that. Used to speak for Boehringer, but have not for like 1.5 years, 2 years. So again, no bias. A few personal disclosures, if I may. I would much rather sit and have a discussion with you as opposed to lecturing to you or talking to you, speaking at you. What I would typically do in a non-virtual, like filmed live environment, have a lot of interaction. Instead, when I ask a question, I invite you to think about it. I'll try to guide us through it so we don't lose the virtual audience so that they can hear all of the audio and not just your response or your question. But if you have a question at any point in time, use the iPads to type it in, and hopefully I'll remember to pause maybe midway through to ask if there are any like burning questions or pressing questions related to COPD. Learning objectives, again, just like disclosures, you can read those just like I can. But the overarching objective of today's talk is to, when we leave this room, we rethink COPD. We rethink etiologies of COPD. To a degree, we rethink diagnosis or diagnosing COPD, and we certainly rethink our management of patients with COPD.
All right, we are starting off with a question. How many people with COPD do you provide care for in a typical week? A, 1 to 4, B, 5 to 10, C, 11 to 15, D, 16 to 20, E, more than 20, or F, not applicable.
Music while you think.
All right, decent amount there.
Say 1 to 4, 1 to 5.
All right, let's get right to our pretest questions. So we're going to talk about Judy, who is 48 years old, and she presents with persistent mild shortness of breath, also with a history of hypertension and childhood asthma. She has never smoked, lives with a non-smoking partner, and works in a furniture manufacturing plant. Which of the following is the best next step for her, according to the Gold Report of 2024? A, encourage environmental changes. B, evaluate for undiagnosed COPD. C, refer to cardiology for an echocardiogram. Or D, prescribe a new inhaler for asthma.
Bit of a giveaway there, right? Okay. Sorry, Tracy.
Oh, no. That's good. All right, I'm going to lean on you.
Oh, you
Oh,
lean
there
all
we
you
go.
want. Lean
A
all you
patient
want.
with COPD is receiving vilanterol and
Umeclidinium.
with good technique and adherence. He has had 4 hospital admissions for exacerbations in the past year and has a blood eosinophil count of 355. What is the next best step for his treatment? A, we're going to add dupilumab. B, we're going to change to fluticasone, vilanterol, umeclidinium.
Nailed it.
C, we're going to change to nebulized solution. Or D, we're going to change to olodaterol or tiotropium. All right, we're going to learn about this one.
Perfect.
All right, more questions. Linda, who is 59 years old, has been diagnosed with COPD, Group B, and started on a LABA-LAMA combination this week. What other strategies would help optimize her COPD care? A, a prescription antitussive. B, an inhaled corticosteroid. C, cognitive behavioral therapy. Or D, pulmonary rehab.
All right.
Which of the following inhaler devices would you select for a patient with osteoarthritis of the hands and poor inspiratory effort? A, metered dose inhaler. B, dry powder inhaler. C, soft mist inhaler. Or D, a nebulizer.
All right. Thank you. So this would be the more interactive part. So I will guide you through this as much as possible. Going back to the guideline-based diagnosis here. If I were to ask you what your go-to source is, so to speak, guidelines for COPD, you should answer GOLD. The GOLD report is something that is evidence-based. It's reviewed and published on an annual basis in October or November, and is the go-to source, the one-stop source for the management of patients with COPD, as well as the diagnosis of COPD. I would follow that up by asking you how many people in the United States carry a diagnosis of COPD. We'll do some hand raising. Less than 10, if you think it's less than 10 million people, raise your hand. Seeing no takers here, less than 15 million. Have one, 15 to 20 million. All right, perfect. Right? And so CDC reports there's somewhere around 16 million people in the United States that carry a diagnosis of COPD, but they also report, just like they have for years, as diagnosis has been increasing, that there are just as many patients who likely have COPD that are unrecognized or undiagnosed. Where do you think COPD ranks in regard to mortality in the United States? Any takers for first? Ranks first? No? Good. Second, third? A couple. I think I see lights are super bright. Fourth? Some more in line with 4. Fifth? Sixth. So we can agree top 10. We have a slide or a bullet point in the slide built later that says 6th ranked cause of death in the United States, but CDC, NHLBI, et cetera, just released mortality data for 2023, and COPD is currently ranked as the 5th leading cause of death in the United States. It has been as high as the third leading cause of death in the United States within the past 5 to 10 years. So somewhere between 3rd and 5th. Where do you think it ranks in regard to disability? First, any takers? Second, there's one taker on first. Top 5? Okay, perfect. A lot of hands. Second leading cause of disability in the United States per disability adjusted life years, trails only ischemic heart disease, and far surpasses disability related to diabetes. If you were to guess where COPD ranks in regard to NIH funding, and this is an imperfect answer, but would you say top 10? Federal dollars? I see some head nods. So a few, top 20. Some more, top 50? Almost certainly, right? Well, if you go to the NIH website, and it's a rank order list, but it's not numbered. You have to count down. Per my count, it ranks 174th in regard to NIH funding currently. There's a method to the madness. I ask these questions to establish that that's a disconnect, is there not, between third to fifth leading cause of death, second leading cause of mortality in the United States, but the NIH funds it to the tune of like 175th. Why do you think that disconnect exists? There was a shout from the back, tobacco. Yeah, I was going to ask, who has COPD? If you had, it's a judgment-free space, but if you had to stereotype a COPD patient, who has COPD? And what I heard from the back is tobacco. It's cigarette smokers, tobacco smokers, combustible tobacco use. Again, method to the madness, I ask these questions to point out that in GOLD, per GOLD 2023 and moving forward, GOLD changed their definition for COPD with a singular word, and that word is heterogeneous. And it is a centralized call to action to rethink the disease as a whole. COPD is no longer a disease reserved for smokers. Hopefully by pointing out that it's a heterogeneous disease state, multiple etiologies and or root causes, you choose your verbiage there. Because it's not a disease of smokers, we can cast a wider net, start to explore the different etiologies, endotypes, phenotypes related to, maybe diagnose earlier, and treat more favorably. But per GOLD 2023, 2024, and 2025, I'm almost certain when it's published later this year, COPD is a heterogeneous lung condition, chronic in nature, persistent, often progressive airflow obstruction. And possibly, like, we grow in our sympathy and or empathy related to COPD patients because it is a heterogeneous disease state. So some of the things that I've already pointed out, I'll try to highlight the things that I haven't. COPD contributes to approximately 3 million deaths annually, globally. Prevalence of COPD is continually underestimated, established that, projected to increase due to the ongoing risk factor exposure in our aging population. And then again, now we're casting a wider net in regard to diagnosis and trying to rethink the disease, both from a research perspective and clinically. And despite being both preventable and treatable, gaps in diagnosis and management remain. But hopefully we close those gaps, one in this 30 or 45 minutes that we have left today, but moving forward over the weeks, months, and years to come. So why is COPD underdiagnosed? From a patient perspective, again, there's lack of sympathy, lack of empathy. You're a smoker, you should not have smoked. It's a consequence of smoking. But don't do a good job with education. Patients don't think about it. It's not on top of their differential list, so to speak. They start to get progressively short of breath, whether that's exercise induced or related to exercise, or that's just on a day-to-day basis, activities of daily living. So, and then pathophysiology of the disease or symptoms of the disease lag well behind pathophysiology. So patients don't recognize it, don't think about it. As PCPs, limited spirometry. A lot of us don't have handheld spirometry in our offices. We're uncomfortable with spirometry and interpreting spirometry results. Again, possibly I would debate a lack of sympathy and or empathy for these patients, whether we want to call it out or not. Then we have a lot of time-related limitations as well. We see patients, every 15 minutes? Is that a pretty good estimate for what you're seeing in practice right now? Every 15 to 30 minutes, and you have to document. So again, it fails to make the differential list, lack of sympathy and or empathy, and a lack of education surrounding it, both for patients and primary care providers.
Although smoking is an important risk factor for COPD, what percentage of patients with COPD have never smoked? That's never smoked. A, 15%, B, 25%, C, 45%, D, 55%.
Pretty good guess, 15%. Pardon me as I put my water down. Correct answer is 25%. Somewhere in the range of 20 to 30% of patients who have or carry a diagnosis of COPD have never smoked. Many of them have never been exposed to a smoker, so not even secondhand smoke, debatably tertiary smoke, but 25% have never smoked. 50% of patients who do smoke are never diagnosed with COPD, whether they have pulmonary limitations or not. So again, no longer a disease for smokers, just reserved for smokers. If you walk away with one thing from this 45 minutes to an hour, and this slide in particular, again, I ask that you reconsider the diagnosis of COPD, the management of COPD, and that's all secondary to the etiologies of COPD. So consider COPD in any patient who presents to your clinic or your office who has dyspnea. It should be on your differential list. Certainly if they have a chronic cough, sputum production, previous or recurrent rather, more so than previous lower respiratory tract infections, but maybe you catch them earlier and it's just one previous lower respiratory tract infection. But any patient with dyspnea, consider COPD, have COPD on the differential list. When you look down to prior exposure and disease state related risk factors, certainly tobacco smoke, but it's environmental exposures. It's cooking. So like chefs that are in a kitchen all day long, they're cooking with gas, experience COPD. Stonework, carpentry, so woodwork, furniture manufacturing, similar to the case we built earlier. All of these patients can experience COPD or be diagnosed with COPD, and it should be on the list, a differential list based on environmental exposures, again, not just tobacco smoke. 15% of patients who have a diagnosis of COPD in otherwise developed countries have COPD secondary to environmental exposures. And if I may take a couple liberties here, if you read through Gold 2024, there's a lot of new nomenclature and taxonomy related to COPD. There's COPD-C, that's cigarette smoke exposure as environmental exposure. There's COPD-P, which is pollutants, exposure to pollutants. Another thing I didn't point out here, but biomass fuel, like byproducts, we think that more as a less developed country problem. But if you look at a map with cases of COPD, county by county, there's still a lot of patients or a lot of people that are using biomass fuels, burning wood for heat and or food, to prepare food in Appalachia. So things to consider. Again, multiple etiologies, heterogeneous disease state. Per Gold, as of right now, it is still mandatory to have abnormal spirometry or forced spirometry that demonstrates obstruction. So an FEV1 to FVC of less than 0.7 or 70%. But to just reiterate, double down, triple down, whatever you want to say on this slide, consider COPD in any patient that presents to your clinic and or office that complains of dyspnea, and ask questions related to their environmental exposures, not just cigarette smoke. If you have a handheld spirometer, and I would suggest that everyone have one in clinic, I think they run about $2,000 depending on the make and model. Easy to use. When I had a respiratory care clinic, I would use a handheld spirometer in clinic. Now, was it perfect? No. If I used it appropriately, like at a pulmonologist's office, and I was a respiratory therapist, and I was getting spirometry for a patient or PFTs for a patient, a little more reliable, debatably more accurate, or not even debatably more accurate, but slightly more accurate. But this gives us a starting point. If we have handheld spirometry in our clinics, we have disposable mouthpieces, and we walk away for a minute to get the handheld spirometer, and while the patient's doing other things, come back and ask them, similar to respiratory therapists, like blow into this, blow hard into this, you encourage them to blow into the device. We can establish within a degree of certainty whether or not the patient has obstructive respiratory disease. And if you look at the flow loops, and you're much more familiar with this than I am, or should be, with diagnosis, what we're looking for is that flattened pattern, that flattened flow loop, which is an obstructive pattern. I mentioned taxonomy and terminology related to COPD per Gold 2023 and Gold 2024. A lot of these aren't going to be important to us in practice in clinic. So early COPD is related to like research, mild COPD and young COPD, not something we really need to consider because it doesn't change treatment course. But two things that are emerging that may change treatment course and a lot of ongoing research are pre-COPD and what is known as PRISM, which is preserved ratio impaired spirometry. With pre-COPD, if I think of it, we'll talk about the use of CT scans to diagnose COPD. If a patient does not have impaired spirometry, but per chest CT, it looks like or appears to be a pattern of emphysema or something similar, that could be considered pre-COPD. And then PRISM is that preserved ratio impaired spirometry where the FEV1 to FVC per gold doesn't quite meet diagnostic criteria for gold, but the FEV1 itself is less than 80%. PRISM, I will go back just to dwell here for just a second, we believe that it exists in roughly 10% of our COPD population, is more common in female patients, is more common in patients who are overweight and or obese, more common in patients with a history of smoking or current smoking. It's a relatively fickle phenotype at present. Roughly a third of these patients that we could call PRISM are expected to develop airway obstruction per gold diagnostic standards at some point in time over the course of 5 years or 10 years after we recognize PRISM, if we do recognize PRISM. So a fickle phenotype, but something to have maybe back of mind as you start to review literature and or treat patients with COPD. Patient comes in, we get spirometry, handheld, we refer to pulmonology. Pulmonology gets PFTs in clinic, but a patient now carries a diagnosis of COPD. When they come in, we want to evaluate their symptoms. There are a couple different ways to evaluate symptoms I'm sure you're familiar with. A simple, straightforward way, 5-question-ish or 5-point scale related to symptoms, purely respiratory symptoms, would be the MMRC, has been around since the 1960s, so what's 64 years now, which is just an assessment of breathlessness alone. Where I like to start with a patient and just questioning, as opposed to have them fill this out, is, hey, if you're walking to someone that's your age, you're out in the evening for a stroll, or you're walking in the clinic or the hospital or the job site with someone who is your age, do you have to stop because you're breathless at any point in time, whereas they can continue or would continue? And if they answer yes to that, or if they're walking on the level at their own pace, if they have to stop at some point in time for breathlessness, they would be considered an MMRC of 2, which is obviously symptomatic. My preferred tool in evaluating patients with COPD is the COPD assessment test, or CAT, which is 8 different questions on a scale from 0 to 5 that I usually allow patients to direct themselves. I mentioned earlier walking out of the exam room, going to the handheld spirometer. This is typically where I leave the patient with this evaluation and ask them to fill it out as honestly as possible. Do you never cough, or do you cough all the time? And you come back in the room and you calculate their score. A CAT score of less than 10 is uncommon in patients with COPD, whereas a CAT score of greater than or equal to 10 is very uncommon in healthy individuals. And this correlates with something known as the St. George's Respiratory Questionnaire, which is 25, 30, 50 questions, somewhere through there. Haven't used it in a long time. This is simple, it's straightforward. It can be provider guided, but I typically allow the patients to direct themselves. And what we're doing there is evaluating a patient's symptoms so that we can grade them and provide appropriate therapy.
So I think you guys are paying attention. So we're back to Judy, who's 48, presents with persistent mild shortness of breath, hypertension, and childhood asthma. She's never smoked, lives with a non-smoking partner, works in a furniture manufacturing plant. Which of the following is the best next step for her according to the GOLD report of 2024? A, encourage environmental changes. B, evaluate for undiagnosed COPD. C, refer to cardiology for an echo. Or D, prescribe a new inhaler for asthma. They're paying attention.
They are. Thank you for that. Yeah, of course. Again, I'll say it for the 19th, 20th time, maybe somewhere through there, maybe even more than that, not just a diagnosis for smokers. It does not appear on your differential list just in tobacco smokers or those who consume combustible tobacco. So evaluate her for undiagnosed COPD. Risk factor for her would be the furniture manufacturing plant. To relate this to actual clinical practice, one of the first patients I saw in practice, so I have a history in rounding with an internal medicine service at a teaching hospital in Charlotte, but ran a pulmonary care clinic one afternoon a week for a couple of years pre-COVID. One of my first patients was from Detroit, had relocated to the Charlotte area, had spent a lot of time in a paint booth or similar in auto manufacturing in Detroit before we knew that those things that he was inhaling were bad for him and he should have some kind of respiratory protection, and was diagnosed with COPD. So environmental exposures are key in your evaluation of these patients. Inhaled therapies for COPD, so the patient comes in, we've diagnosed because we've rethought COPD, we've collected PFTs or spirometry, they carry a diagnosis of COPD, we've assessed their symptoms, and what that allows us to do is place them on a scale. But we'll walk you through the remainder of Judy's case as we figure out what pharmacotherapy she needs to be placed on. So pulmonary clinic, she has mild dyspnea, we mentioned that, slight decrease in physical activity, persistent cough that she says is sometimes persistent, or productive rather, carries a diagnosis of hypertension, mentions childhood asthma, is a bit overweight. I consider that a bit overweight in the Southeast. I don't know how things are in Pennsylvania. A BMI of 27. Let's see, never smoked, lives with a non-smoking partner, so no primary exposure, no secondary exposure. There's the furniture plant manufacturing for approximately 25 years. Prior chest x-rays have been unremarkable. Someone thought about a differential diagnosis, referred her to cardiology for an echo, and ejection fraction returned to 65%. So we're rocking along pretty stone cold normal. Looking at these things, evaluating these things, would you say Judy has COPD? We're going to evaluate her for it. We established that, but would you say that she's trending towards COPD? I see some yeses. I see some nos. Right. We delve a little deeper. Order PFTs, spirometry returns, FVC is 79% predicted. FEV1 is 73% predicted, so less than 80%. FEV1 to FVC is 0.65 or 65%, so she meets criteria for obstructive lung disease. You want to assess her symptoms, you conduct a COPD assessment test, which returns with a score of 9. You want to double down on those symptoms and assess just purely respiratory function, and you get an MMRC of grade of 2. There's a chest CT for some reason. Maybe you didn't order it, maybe you did. But the chest CT interpretation is multiple focal areas of lobular air trapping consistent with small airway disease. Starting to look more and more like COPD, right? You get bloody eosinophils, you order a CBC with diff, and you get 114 cells per microliter. So I'm going to ask you again, dug a little deeper, you double-clicked, full pulmonary workup, like a very thorough pulmonary workup, and you ruled out some of your other differential list. Would you say Judy has COPD? So I see a couple heads that were saying maybe not earlier and now saying yes. Perfect. If so, and we've said so, how would you classify her COPD? Now I could go back to the slide that talked about mild COPD, young COPD, PRISM, pre-COPD, et cetera. And the only one of those criteria that Judy would meet would be young COPD because she's less than the age of 50. But again, that bears no weight clinically. What I'm asking more than anything right now, not that taxonomy, but how do we group her to decide what her appropriate pharmacotherapy should be? So you look at this schematic here, moving from left to right. You've diagnosed COPD. I don't know that I said post-bronchodilator, FEV1 to FVC, but let's assume that I did. So meets spirometric classification of COPD. Not going to pay a lot of attention at this point in time with the green. Grading of COPD is more related to pulmonary rehab, oxygen therapy, medical procedures, so like lung resection, et cetera, and points toward mortality. Has no bearing on what we do with patients' pharmacotherapy. And get over into the right-hand side there. Her MMRC was 2. her COPD assessment test score, or CAT score, was 9. So if you would look, and we're unaware of any exacerbation. So no exacerbations, to our knowledge, puts her on either in group A or group B. MMRC of 2 would put her in group B, but a CAT score or COPD assessment test score of 9 puts her in group A. I don't know what your experience is, but my experience is we don't see a lot of group A patients. Dyspnea is not significant enough for the patient to present, typically. So I like the gray in medicine a whole lot. I could ask for a show of hands who would do just a bronchodilator, and I would expect to see a fourth of the room, a third of the room, up to half of the room, maybe more. And the remainder of the room should say a LABA/LAMA in combination, a long-acting beta agonist coupled with a long-acting muscarinic antagonist. And my opinion would be to start with the LABA/LAMA in combination because of primary literature and the benefit established there. Again, if you have questions as we go, type them into your iPad, and then we will stop at some point in time and entertain those. So I'm going to exhibit some bias, exert some liberties here. As you look at these next two slides that are tables related to LABAs, LAMAs, LABAs, LAMAs in combinations, LABA, LAMA, ICS in combination, don't put a lot of effort into the LABAs for patients with COPD because LAMAs, per primary literature, are a little bit better than LABAs as monotherapy. So with the LAMAs, there are 3 that really stick out to me. Again, no bias here, but there are 3 that really stick out to me. You have one that's in nebulized form, which is revefenacin, once daily nebulizer device, and you can use that in a typical nebulizer, whereas the Lonhala, you cannot. You have to have a special nebulizer for it. It's the company's nebulizer. Tiotropium, which is available in a dry powder inhaler, which is the old HandyHaler device. Looked like an egg. I'm sure you recall it. But more recently, over the past 5-7+ years, it's been available in a Respimat, which is a soft mist or slow mist inhaler, pharmaceutically elegant device. And then you have umeclidinium, which is a dry powder inhaler. Would be the 3 that I would know from this slide or pay attention to from this slide. Moving on to like LAMA-LABA combination therapy. Anything you can imagine is available there as well. There are 2 DPIs or dry powder inhalers. There's 1 metered dose inhaler, MDI. There's also the Respimat device, which is the soft mist or slow mist inhaler. Not going to use a lot of LABA ICS, long-acting beta agonist, and inhaled corticosteroid combinations unless the patient has a history, a well-established history of asthma, or you think upon presentation and diagnosis to get an eosinophil count, and that eosinophil count is greater than 300. And then you have triple therapy, which is an easy answer when you're seeing these patients. I'm just going to put you on all of it, and some of it's bound to work. I would advise against doing that, and we'll get into some of those slides a little bit later related to inhaled corticosteroids, and they're not as benign a medication as many of us think. So after you establish an initial therapy, a diagnosis of COPD, and initial therapy, which is the grouping of A, B, and/or E for patients with COPD, you're going to follow up with them, typically a month later, maybe a little bit earlier than that, maybe it's 6 weeks. If that patient comes back to you and they complain of dyspnea, which is one of our phenotypes, well-established phenotypes in COPD, and they're on monotherapy, you're going to escalate that monotherapy to dual therapy, a LABA/LAMA in combination. If they're on dual therapy, and to be frank, if they're on monotherapy, you're going to evaluate these things too. Where you want to start in evaluating these patients is adherence, and I'll drone on more about this a little bit later as well, how they use their device, if they have access to their device, and you want to establish adherence and access before we knee-jerk reaction, add a LAMA to a LABA, or add a LABA to a LAMA, like dual therapy, and we stack on monotherapy. If they're on a LABA/LAMA in combination and they are adherent and they do have access and you have faith in that, you could consider switching the device and/or molecule. So moving like a LAMA from a umeclidinium to a tiotropium, and that's what I mean by changing the molecule. You would implement or escalate non pharmacology. If they are smoking, you want them to stop smoking. We'll get into that a little bit later too. But that's investigate and treat other causes, different diagnosis, because there are a lot of comorbid conditions with COPD. If the patient comes back and they've had an exacerbation in the 4 weeks since you've seen them, 6 weeks since you've seen them or longer, again, it's assess adherence, assess access, always those things, maybe assess other causes. But once you've ruled out those things and you've established adherence and access, you're just escalating therapy. And it's a bit different than dyspnea. And if they're on monotherapy, you would get an eosinophil count, a serum eosinophil count. If they're greater than or equal to 300, you would escalate to triple therapy because of the inhaled corticosteroid. But if they're less, you add a LABA, typically to a LAMA, so dual therapy. If they're still complaining of exacerbations or they've had exacerbations after you've escalated to dual therapy, you get a blood eosinophil count again, a little bit different. If it's greater than 100, you'd add an inhaled corticosteroid. If it's less than 100, likely no benefit associated with the inhaled corticosteroid, and you would move on to one of these agents down at the bottom. And this is typically where we would stop. This is typically the comfortability of a primary care provider, but not always. So in talking through some of these options down at the bottom, you have roflumilast, which has been available for the better part of 15 years, a bit controversial, but where we've established its benefit if a patient is on adequate inhaled pharmacotherapy, so a LABA in combination or triple therapy, and they're still having exacerbations in your patients with an FEV1 of less than 50% predicted or a history of chronic bronchitis, roflumilast may benefit that patient. It takes weeks to work, so it's not an immediate impact. It is a PDE4 inhibitor, so it's anti-inflammatory properties. It's a once daily medication, which is better for adherence, but it has a lot of adverse effects, and some adverse effects we don't want in our patients with COPD. So GI upset, nausea, vomiting, diarrhea, weight loss, and a lot of these patients are underweight to begin with, certainly in more advanced disease. You could add azithromycin chronically. We all know it as an antibiotic. It's not without its warts either. One large study, something like 1,000 patients, established there is some benefit there. There's some suggestion that benefit wanes over time in regard to reducing exacerbations. And then you have QTC prolongation, arrhythmias associated with it, hearing loss associated with it. There's a lot of question as to whether or not it pressures antimicrobial resistance. So one of those two medications typically, if you're having trouble deciding which one of those two, there's a trial ongoing right now that's recruiting called Reliance that is looking at just that. When we get to maximal inhaled pharmacotherapy, is it roflumilast? Is it azithromycin? Is it neither? Dupilumab we'll call out a little bit later too. It's newer to the game. It's a monoclonal antibody that decreases eosinophilic driven or type 2 inflammation. Inhaled corticosteroids and the evaluation of eosinophil count. Always like to remind, so teaching a school of pharmacy, have pharmacy students, interact with pharmacists all the time. You would be surprised how many of them could tell you, yeah, inhaled corticosteroids decrease inflammation, but they can't tell you that's eosinophilic driven inflammation. It's type 2 inflammation. And we know that COPD is primarily a neutrophilic driven inflammation. So you have to establish eosinophil count, or we've established kind of this rough eosinophil count of greater than or equal to 300 cells per microliter as a cutoff of patients that would derive benefit from an inhaled corticosteroid. So benefit would outweigh risk versus risk outweighing benefit. And when I say benefit, risk specifically, same thing with pharmacy students, same thing with pharmacists. If I say what's an adverse effect of an inhaled corticosteroid, someone throws out thrush every time. Yes, of course, thrush. After you take an inhaled corticosteroid, swish and spit to prevent thrush. If you're working with pediatric patients, maybe some stunting of growth. I don't know, it's like 2 centimeters, maybe a centimeter or 2 centimeters in patients with asthma, pediatric patients that have an inhaled corticosteroid. The thing that we don't think about is the risk of pneumonia associated with inhaled corticosteroids. There was a post hoc analysis of TORCH, if I'm remembering correctly, that said at 6 months, you prevent 3 exacerbations for every 1 case of pneumonia with inhaled corticosteroids. At a year, you prevent 2 cases of exacerbation for every 1 case of pneumonia. You get out to 2 years and it's a 1-to-1, You get up to 3 years and you have 2 cases of pneumonia for every 1 exacerbation prevented. Now, TORCH was 90s maybe, early 2000s. I'm blanking, I'm getting older, and I apologize. That was before we had these cutoffs of greater than or equal to 300 cells per microliter, or 100 if it's dual therapy as you move to like triple therapy. Questions about any of that, please type it into your iPads. I mentioned earlier, if a patient has a history of asthma, 10 years ago, there was something known as asthma COPD overlap syndrome, and then it went away, but it reappeared. In GOLD 2023, we're now referring to that as COPD-A. So asthma, poorly controlled asthma for years and years, eventually lead to like chronic progressive obstruction, or a clinical picture that's very similar to COPD. So if a patient has a well-known history of asthma, you could consider a LABA ICS in combination. Risk would be minimized, benefit should be greater in those patients. And then you have patients with high exacerbation rate that are on LABA-LAMA in combination. And GOLD suggests 2 alternative pathways. This is a prop, I'll bring it out later. Sorry, I hit it with my hand. You could escalate those patients to triple therapy or add roflumilast or azithromycin if the eosinophil count's less than 100. The vast majority of our patients, the vast majority of the patients I see at least, are still on an inhaled corticosteroid despite 7 to 8 years worth of evidence to suggest that it's beneficial in maybe 20% of our patient population. You can be pretty comfortable withdrawing those inhaled corticosteroids for patients that are not likely to derive benefit without increasing their risk of exacerbation. So per the European Respiratory Journal, or per an article published in the European Respiratory Journal as guidance, if the patient's not having exacerbations, the eosinophil count's less than 300, we should consider withdrawing corticosteroids. There's the gray that exists if they're having exacerbations. One would be considered, one exacerbation considered severe that required hospitalizations, or a hospitalization. It's a conversation with the patient. How did you feel before this? Did you investigate eosinophils before the inhaled corticosteroid was added? Do they think they derive benefit from it? Do they have access to it, et cetera, before you make the decision related to withdrawing therapy? But if you have eosinophil counts greater than 300 and the patient's having exacerbations, or if they're just having an eosinophil count of greater than 300, there's likely benefit there as opposed to risk. There's another way to look at it too, which is percentage of blood eosinophils, and your comfortable ability, if I could spit that out, is right around the 3% mark. Less than 3%, you feel pretty comfortable withdrawing corticosteroids without patient having an exacerbation, but greater than 3%, it's a conversation you have with the patient and you dig a little bit deeper. Considerations of pneumonia. I think I've droned on a little bit too much about this with inhaled corticosteroids. One thing I would like to point out here, studies have shown the incidence of pneumonia is greater with fluticasone versus budesonide. That's an inhaled corticosteroid. So a nice little schematic here of should you include inhaled corticosteroids, history of exacerbations, severe exacerbations, exacerbations that require hospitalization, 2 or more moderate exacerbations a year, so the patient's on corticosteroids, systemic corticosteroids and or antibiotics at least twice a year, and blood eosinophils are greater than 300 cells per microliter or greater than 4%, yes, add an inhaled corticosteroid. There's the gray area, there's the maybe, there's the 1 moderate exacerbation or less than 2 moderate exacerbations, no hospitalization, blood eosinophils greater than 100 but less than 300, then you'd say no, or I would say no. If the patient has a history of recurrent pneumonia, lower respiratory tract infections, blood eosinophils are less than 100, or they have a history of mycobacterial infection. I said we'd come back to dupilumab. I don't know that any of us get to this point in therapy. Honestly, don't know. It's very niche. I'll say that. This is the study conducted here, published in New England Journal in 2023. Patients were on triple therapy, patients that were adherent to triple therapy that were continuing to have exacerbations. There's benefit to adding dupilumab to those patients, or for those patients. Reduces their risk of exacerbation by roughly 1/3. Other agents on the horizon, COPD is on the cusp of really blowing up because of GOLD 2023 and a couple of reports, publications that spurred that update. The only one I'll talk about here, ensifentrine, top one here, the dual PDE3, PDE4 inhibitor was just FDA approved in June. So of this year, similar to roflumilast, it has PDE4 inhibition properties. So it's anti-inflammatory properties, but it has a much greater affinity, like 3,000 times the affinity for PDE3 and PDE3 inhibition than PDE4. So it bronchodilatory properties. Relatively benign adverse effects in clinical trials, phase 3 clinical trials, and some strange ones: back pain, urinary tract infection, GI upset are the three that I can think of right now. But at 24 weeks, this oral medication significantly enhanced or increased FEV1 and decreased symptoms related to COPD. So I will be following along rather intently with post hoc analysis and post-marketing reports related to ensifentrine. Just to speak to the right-hand part of the slide here, mepolizumab and benralizumab were both IL-5s, not dissimilar from dupilumab, that really didn't show much benefit in studies.
Okay, I know you've been paying attention. So we're back to our patient with COPD who's receiving vilanterol, mecolidinium, and has good technique and adherence. He's had 4 hospital admissions for exacerbations in the past year and has a blood eosinophil count of 355. What is the next best step for his treatment? A, add dupilumab. B, change to fluticasone, vilanterol, mecolidinium. C, change to a nebulized solution. Or D, change to olodanterol tiotropium. Ooh,
Yeah, perfect.
paying attention.
Yeah, they were on top of that one from the start. So if you look at the question, you really break it down, the rationale here for this patient. Eosinophils greater than 300, right? Criteria for inhaled corticosteroid. Patient comes in on dual bronchodilator therapy, bronchodilatory therapy with vilanterol and mecolidinium. You assess good technique or decide they have good technique. They're adherent. They have access to the medication. Then the next step is to add inhaled corticosteroid based on the eosinophil count. You wouldn't change the molecule because of the eosinophil count. No need to change the nebulized solution because you assess their technique with the device. And dupilumab is for patients that are on triple therapy that are still having exacerbations. Strategies to optimize outcomes for these patients and things we oftentimes don't think about. Give you another patient, meet Billy, and I don't know if you watch The Righteous Gemstone, but this is Uncle Baby Billy Freeman. 66-year-old man presents after recent hospital discharge for a COPD exacerbation, reported to have, upon review of electronic medical record, 1 to 2 exacerbations a year, obviously has COPD with chronic bronchitis as a past medical history, HFpEF, hypertension, gastroesophageal reflux, using a LABA/LAMA fixed dose inhaler in combination, voices adherence, social history is a current smoker, just like 40 to 50% of our COPD patients are. Blood eosinophils, because you've collected them, are 73 cells per microliter. FEV1% predicted is 40%. That was measured last year within the past 12 months. MMRC grade is 2. COPD assessment test score is 18. Think through how we could optimize this patient's care. And we'll come back to it. So in optimizing a patient's care, there's a stepwise approach that I employ for each patient. And it's, we group the patient or the patient's grouped for us, and we establish whether or not they're on appropriate pharmacotherapy, inhaled pharmacotherapy. Is it monotherapy? Is it dual bronchodilatory therapy? Is it triple therapy? So we establish or analyze or assess, is the pharmacotherapy right? And after you establish whether or not the pharmacotherapy is right, so is it a LABA/LAMA, LABA/LAMA combination, LABA/LAMA ICS, what devices are available? So if we're initiating care, what devices are available for these patients? I think that it's imperative we all have demo devices. Reach out to pharmaceutical companies, ask for demo devices, but you have those demo devices readily available in your clinic, because you want to watch a patient try to manipulate a device before you decide on a device to prescribe that patient. So what is the pharmacotherapy right? What devices are available? Can the patient manipulate the device? You'd watch them do that with a demo device in clinic. And the one thing we oftentimes leave out, which is where this prop comes in, is you would assess inhalation maneuver, because every one of these devices have different inhalation maneuvers. I'm going to skip ahead, and I'm going to skip right back, so forgive me. Specifically, what I'm interested in is if you are going to prescribe a dry powder inhaler, there's a different maneuver for a dry powder inhaler versus an MDI versus a soft mist or slow mist inhaler. So this is an in-check device. Raise your hand if you know what this device is or if you've seen one of these before. It's a really nerdy thing for people that are into respiratory medicine to have. But what this does, it assesses a patient's peak inspiratory flow rate, annotated here as PIFR. And it's a way to quantify their maximal peak inspiratory flow rate. And with dry powder inhalers, patients have to generate enough inspiratory force to not only lift the powder from the blister pack in the device, but also dissociate the actual medication from the carrier molecule, which is typically lactose. So if patients talk about a sweet taste in the back of their mouth with a dry powder inhaler, that's the carrier. That's the lactose. But they have to generate enough inspiratory force to dissociate the LABA or the LAMA or the LABA-LAMA and ICS from that carrier molecule so that it gets into the lower respiratory tract where it actually works. Does that make sense to everyone? So when I walk patients through a new inhaler device, or we're prescribing a new device for them or we're switching a device, I ask them to tell me how they're using their inhaler. If I have a demo device, they show me how they use their inhaler. And then when they get to the point where they say, well, then I inhale, I hand them this device with a disposable mouthpiece and say, show me how you inhale. Because if a patient's not inhaling correctly, so generating enough inspiratory force for that dry powder inhaler, or they switch from a dry powder inhaler to a soft mist, slow mist inhaler, or an MDI, and they're inhaling too quickly, the medication is not getting into the lower respiratory tract where it belongs. Again, it's so simple when we think about it, but it's not something many of us think about on a regular basis. So going back to key principles here, I'm going to point out the bottom two bullet points here, what's down here in blue. Healthcare providers should be familiar with all the devices they prescribe, should have demo devices available, again, to observe a patient manipulate the device to determine if it's the best device for the patient. And choosing the device, once you've established the appropriate pharmacotherapy, is a shared decision-making process between provider and patient. There's ample data in that asthma population that shared decision-making in regard to an inhaler points to better outcomes, and we can extrapolate that data to patients with COPD. One other thing I'd like to point out here, avoid switching devices unnecessarily. If we can get the medications the patient needs in one device, that points to better outcomes, and we avoid switching from a DPI to an MDI or an SMI, because the number of times I've seen a patient move from a DPI to, say, an SMI, a soft mist inhaler, and inhale incorrectly, and all of the medication ends up in the back of the oropharynx instead of the lower respiratory tract. It's fingers and toes. You could count for quite a while. And inspiratory maneuver is something that can be taught and should be reiterated at every visit. It should be reiterated every time they pick up a prescription as a CVS or a Walgreens or wherever else. Talked about this a bit, but the difference in inhalation maneuver between a meter dose inhaler and a soft mist inhaler. Both a meter dose inhaler and a soft mist or slow mist inhaler require coordination between activation and inhalation. The soft mist inhaler is a bit more passive of a device than the meter dose inhaler, but it's the slow inhalation, it's the holding the breath, including inhalation for up to 10 seconds, and not, like starting a leaf blower like you would with a dry powder inhaler. So the deep, forceful, sharp inhalation. Looking at data related to like misuse of inhalers, 70% of patients get at least one step incorrect. Most of the time it's either device preparation or inhalation technique, and sometimes it's not holding the breath or for as long as possible, up to 10 seconds. In a study, and they don't have to be dissociated from being taught either, which is why it's important that we reiterate at every visit and every time they pick up a prescription. There was a study of patients that were discharged for a week our follow-up a week post-discharge from an exacerbation of COPD, and only 23% of patients could demonstrate to the respiratory therapist or pharmacist or physician or provider like how to use a dry powder inhaler. And those are relatively simple devices. You open them, keep it relatively level, you don't block the vent, you suck or inhale rather like deeply, forcefully. And then in another study, what percentage of medical interns do you think know how to use and get all 10 steps of using an albuterol inhaler correct? Would you say 75%? Raise your hands. Going less? Yeah, there's a 15 here. Yeah, 5% of medical interns could demonstrate how to use an albuterol inhaler, an MDI, all 10 steps correctly. So again, teach and reteach, and have devices that help you teach and reteach. Non-pharmacotherapy for COPD. Comorbidities exist. I'll jump down to this bullet point. Lung cancer, that's an obvious one because of the environmental exposures, tobacco smoke in particular. But things we don't often think about, cardiovascular disease, heart failure, AFib, and ischemic heart disease are the three most common. And a patient with COPD is 2 times more likely to have a cardiovascular condition or diagnosis than a patient without COPD. Leads to readmission, 30-day readmits, 60-day readmits, prolonged hospitalization, increased mortality. The other comorbidity we don't often think about is depression. So 30% of patients with COPD suffer from depression. That's more than cancer, which is roughly 25% per studies that I've read. I don't know if they're correct or not, but I can tell you what I know. Or heart failure. So if a patient with COPD is experiencing depression, you can start them on an SSRI. Pulmonary rehab helps with some of those things. Don't want to spend a terribly long time there. Reduced toxin exposure, that's pretty obvious. Pulmonary rehab, we'll talk about in the next few slides. Oxygen therapy, if indicated. If patients like SATs on room air get below 92%, certainly below 90%, oxygen supplementation decreases mortality. And then something I have not mentioned yet, consider lung cancer screening and low-dose CT. GOLD 2023 and GOLD 2024 took it forward. Use of CT in diagnosing COPD is a forthcoming thing in partnership or in combination with spirometry. If the patient is smoking, we obviously want them to stop smoking. You have the 5 A's here. Most important thing is offer pharmacotherapy. Varenicline, Chantix, is preferred by the American Thoracic Society over bupropion, Wellbutrin. Can't think of the other brand name. I'm terrible with brand names, so forgive me. Or nicotine replacement therapy. So varenicline is what the American Thoracic Society recommends. And what is cited down here at the bottom in a publication or a report in 2020, they actually suggested that you prescribe varenicline to patients who smoke before they're ready to stop smoking. So even if they tell you they're not ready to stop smoking, you prescribe varenicline for them. In regard to immunizations, the most important per GOLD is influenza vaccination. Only like 45% of adults get an influenza vaccination annually. So patients with COPD, respiratory compromise, need a flu vaccination annually. With the new RSV vaccination, that is level A recommendation per GOLD and per the CDC. COVID-19, I'm not going to wade into those waters. Level B evidence, but should consider it for patients with COPD. And then pneumococcal vaccinations, I guess, would be the other big one. Only like 23%, 25% of patients who are eligible for pneumococcal vaccination have received one. So it's important for our patients with COPD to prevent exacerbations. And yeah, more or less exacerbations. Pulmonary rehab. Several slides on this, but I'm going to summarize because I'm looking down and I'm running tight on time. Pulmonary rehab is wonderful. It is beneficial for these patients. It is reimbursed poorly, very poorly, and access isn't the best for patients, but it's something that we should prescribe and help patients. It's an interdisciplinary, multidisciplinary like approach to these patients' care, prevents hospitalizations, etc. Good for patients with COPD. And a part of pulmonary rehab is typically a COPD action plan, so patients participate in their care. Monitoring follow-up, already talked about this. So I'm going to move to summary slide and then questions. Role of PCPs, I ask you moving forward to consider COPD in any patient who presents with dyspnea, certainly if they've had certain environmental exposures. Don't neglect spirometry. I encourage you to have a handheld spirometer in clinic that you utilize. It gives you a starting point, even if you're going to refer to pulmonology. Symptoms and exacerbations got initial therapy. Are they A, are they B, are they E? What pharmacotherapy class or classes should they be on? Smoking cessation, smoking cessation, smoking cessation. You can read the other half. That's okay.
Okay, I think everyone paid attention. We're going to do well on these. Linda, 59 years old, diagnosed with COPD and started a LABA-LAMA this week. What other strategies can optimize her care? A prescription antitussive, B, an inhaled corticosteroid, C, cognitive behavioral therapy, or D, pulmonary rehab? Strong work. Everybody's listening. You may have to hit that.
Go ahead, advance. Yeah.
All right. Which of the following inhaler devices would you select for a patient with osteoarthritis of the hands and poor inspiratory effort? A metered dose inhaler, B, dry powder inhaler, C, soft mist inhaler, or D, a nebulizer?
Perfect.
Everybody paid attention.
Yeah.
All right, I think we have time for like 2 questions. There was a whole bunch that came in. There were a couple on this topic. You talked a lot about making sure we screen for COPD in a lot of patients and not just think of smokers anymore. What about other environmental exposures like chewing tobacco or even vaping? Are we seeing a lot of COPD happening with that?
Wonderful, wonderful question, and something in all my excitement I left out. We know that vaping, not that it equates to COPD, but there are 200 different proteins in the airway epithelial cells, or epithelium rather, that are elevated secondary to vaping and or tobacco smoke. 113 of those 200 are unique to vaping. So detrimental, most likely, but we can at this point in time point toward if you vape, if you start vaping at this age, if you have a pack year history of vaping, so to speak, which I don't know exactly how to quantify it, that it points to COPD, but we know it's not good for your lungs. Cannabis, similar to combustible tobacco, cannabis use is increasing in prevalence. Smoking, just like edibles, you'd be hard-pressed to convince me that that's not similar to or worse than combustible tobacco smoke without a filter. So and chewing tobacco, no, not to my knowledge. Zen pouches, nicotine pouches, not to my knowledge, but vaping and cannabis, yes, most likely equate at some point in time to COPD based on exposure.
There was some clarification asked about considering patients. So the patients that come into you and say that they're getting dyspneic with exercise, what kind are we talking about? Are we talking about more strenuous exercise or just doing routine things? Do we have to quantify that?
So symptoms related to COPD lag behind pathophysiology. An intent in calling it a heterogeneous disease state in Gold 2023 was to recognize these patients earlier in the disease course so that we can begin effective therapy and slow the progression. We don't have a way to reverse progression at present, but it's to identify the patients earlier. Typically what we see when patients present to clinic, it's dyspnea related to activities of daily living. It's like I mentioned in the MMRC, it's walking next to a person of similar age and having to stop to catch your breath, or walking up a flight of stairs and having to catch your breath. Now, COPD is not the only cause of dyspnea and shortness of breath. I mean, it could be a lower respiratory tract infection, upper respiratory tract infection. It could be heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. But when we typically see patients, they are dyspneic with activities of daily living. What we would like to do and what Goal 2023 and 2024, I hope, prompt us to do is to take that dyspnea, no matter when it occurs, and evaluate COPD in those patients.
Oh, that's great. And for PMDs, and maybe you can help with the pharmacy aspect of it, is there an easy way, I know this probably varies by state, to find out which inhalers or devices may be more affordable for some patients?
That is a wonderful question, and I would love to tell you as a pharmacist I have the answer. I do not. Oftentimes it becomes trial and error with a patient, and you get the pharmacotherapy right, the classes of medication right, you watch them manipulate this device or that, you decide upon an MDI, DPI, or an SMI, you send them out, you may get a PA kickback, to justify the inhaler. It varies so much from insurance policy to insurance policy. It is a barrier to care. The cost of inhalers are if I may say it, it's asinine. Dual therapy inhalers out of pocket are typically $400 or $500. Triple therapy, if my sources are correct, Trelegy out of pocket is like $800. So unfortunately, you have to play the game of trial and error and prior authorizations with different insurances before you get the right one, and I'm so sorry for that. But it's imperative the patient have the right inhaler that doesn't cost $800 so that they are adequately treated.
Good.
Is that a fair answer?
I think that's fair. I think
Okay.
this was awesome, great information. Everyone's got the slides to reflect back on, and I want to say thank you.
Thank
That
you.
was really awesome. The folks on virtual again. We're going to be joined by Dr. Anton Portezin, who is the William B. and Sheila Konar Professor of Psychiatry, Neurology, Neuroscience, and Medicine, as well as the Director of the Alzheimer's Disease Care in the Research and Education Program at the University of Rochester, School of Medicine and Dentistry in Rochester, New York. He'll be presenting on easing the agitation burden, evidence-based approaches to addressing agitation associated with dementia due to Alzheimer's disease.
Okay. Good afternoon, everyone. So I'm very aware that I'm the last thing that stands between you and freedom. So what I'll promise is that I'll try my best to make this last hour worth it to stay. So everyone, I'm trained as a geriatric neuropsychiatrist. I've been focused on the care and study of people with Alzheimer's disease since about 1994. So for over 30 years now. And basically what I hope to do today is to discuss with you the fact that Alzheimer's disease isn't just an impairment in memory and cognition or in behavior and function. But you know, that some of these behavioral disturbances that we see are particularly distressing and hard to manage. We're going to start off basically with looking at my disclosures, and in this space specifically, you know, they are listed here and on your handouts. But we're going to start with we're going to do pre and post questions. Please use your devices to answer this. So the first poll is going to be trying to understand better those that are here or online. How many people with agitation associated with Alzheimer's disease do you provide care for in a typical month? And A, 1 to 2, B, 3 to 5, C, 6 to 10, D, 11 to 15, E, over 15, or not applicable. Okay, so very interesting to see that there's a fairly even range, and that there's a group here that sees a lot of people with agitation, which means to me that it's likely that they practice in long-term care facilities, be it assisted living facilities, memory care, or skilled nursing facilities. But even in regular primary care, these patients are extremely common. Next, so we're going to do pre-test now. Pre-test 1. Which of the following is not one of the International Psychogeriatric Association, the IPA Association criteria for agitation of Alzheimer's disease? So A, a diagnosis of cognitive impairment or dementia syndrome is required. B, behavior must significantly affect one or more aspect of function, that's interpersonal, social, or activities of daily living. C, behaviors must be due solely to a psychiatric disorder, medical condition, or delirium. And D, one or more symptoms from categories of agitation must be present, and those categories can be excessive motor activity, verbal aggression, or physical aggression. So please go ahead. These can be excessive motor activity, verbal aggression, or physical aggression. So please go ahead. Okay, seems like most people centered on one of the answers. We're not going to talk about the correct answer because there's going to be a post-test set of questions as well. So let's go to the next poll. How comfortable do you feel assessing symptoms of agitation associated with Alzheimer's disease? And the range is from A, very uncomfortable, B, uncomfortable, C, neutral, D, comfortable, E, very comfortable. Go ahead and put in your votes. C, neutral, D, comfortable, E, very comfortable. Go ahead and put in your vote. Okay, again, not a surprise here. We had people that saw a lot of patients, others that didn't see as many. So still good to see that many people feel comfortable and very comfortable with assessing this condition. Pre-test 2. Which statement best summarizes the American Psychiatric Association, that's the APA, guidance on the use of antipsychotic medications in patients with dementia? A, may use with no additional concern in this population. B, may use with reduced maximum doses for patients over 65 years old. C, use only when symptoms are severe and cause distress or danger for patient or others. D, use with caution in patients considered at risk for falls and implement additional methods to mitigate risk. And E, do not use in combination with other pharmacological treatments for behavioral issues. So a lot of these make sense, but one of them is built into the guidelines. Go ahead and vote. Excellent, and we'll come back to that later. Pre-test 3. Which of the following is the only FDA-approved treatment indicated for agitation in Alzheimer's disease? A, quetiapine, B, brexpiprazole, C, dexmedetomidine, and D, escitalopram. And I think that's the last vote in the pretest. Excellent. Good range. So there is a potential for learning. So we will now try to get into the presentation proper. So what are the learning objectives? What I hope to do over the next 45 minutes is to leave with you a sense that you can employ evidence-based tools for the assessment and diagnosis of AAD, that you can analyze the limitations of historical treatment options for AAD, including efficacy and safety of atypical antipsychotics, and that you feel comfortable assessing the latest clinical evidence for new and emerging treatment options for AAD. So, neuropsychiatric symptoms in Alzheimer's disease and other dementias are extremely common. We have about 6.7 million people in the US currently that have dementia. And the vast majority of those have Alzheimer's disease. Of those, the vast majority has neuropsychiatric symptoms. And if we focus on agitation or aggression, at some point during the course of their disease, somewhere between 50 to 70% will experience agitation and aggression. These symptoms can happen actually very early in the disease. We sometimes see them in the mild cognitive stage. Then they start to increase. We can see them in the mild stage, and they increase in the moderate and early severe stage, and in the late severe stage, they may start tapering off a little bit. But the prevalence increases, and it's not, it depends very much on where you're looking. So the range of the incidence of symptoms, how common is this, really depends on, are you looking at someone coming to their primary care provider, or are you looking at the group that now resides in a skilled nursing facility? It's going to be much higher in certain settings because agitation and aggression is one of the main reasons why someone puts their loved one into a higher level of care. Agitation and aggression is not only distressing to the patient and distressing to the patient, but it's associated with negative outcomes. What do I mean by that? It's associated with a higher level of medical care, so increased emergency room visits, inpatient hospitalizations, and Medicare expenditures. It is one of the main reasons, along with incontinence, why people are placed into a facility, be that a memory care unit or a skilled nursing facility. And agitation is actually a strong indicator that the person suffering from it, if it goes unmitigated, if it goes untreated, that they will have an accelerated course, that they will have more rapid decline, and that they will have earlier mortality. So there's a meaningful cost, not only in money, but also in quality of life and health outcomes, not only for the patient, but actually also for the care partner. So if you look at the healthcare costs, then if you have people with dementia, like Alzheimer's disease, and you split them into two groups, a group that has dementia and agitation and aggression, and the group that has dementia without this, there is considerably higher cost associated with healthcare if this is present, whether it's not. And most of that extra cost is Alzheimer's disease related, associated with higher frequency of inpatient admission, higher frequency of emergency visits. And here, we're not talking about the facility cost that may be added on, because that isn't considered part of healthcare costs. Like I said before, agitation and aggression associated with Alzheimer's disease is associated with negative patient outcome, both health outcomes and a change to the course of the disease. So you see more frequent infections, higher frequency of depression, more or accelerated mortality and higher transfer to institutional settings. So the burden is considerate, and that's what we need to keep in mind. Now, agitation is really a non-specific term. We use it in our daily life. Oh my God, I feel agitated today. But what is the medical definition of agitation? That's something different. A wide variety of behaviors can also fall into this agitation bucket or this agitation silo. So what are some of the characteristics that we look at? There's increased motor activity, often undirected, restlessness, so pacing, emotional distress is associated with this, and we can see verbal or nonverbal aggression. You can have agitation with aggression, and you can also have agitation that has no physical or even verbal aggression associated with it. So those are not synonymous. When there are aggressive behaviors present, the burden associated with this and the distress, actually both for the patient, but particularly for the care partner, be that a family caregiver or a professional caregiver, the distress rating is so much higher. What are some of the types of aggression that we may see? That can be shouting, cursing, name-calling, threatening words as well. It can be slamming doors, shaking a fist, grabbing, hitting, pushing. What are some of the things that we see with agitation that doesn't have aggressive behavior associated with it? That is more opposition, resistance to care. That is actually the most common one. But we can also see pacing. Someone paces around restlessly back and forth, sitting and rocking back and forth, repetitive hand gestures, repetitive behavior, such as the person, for example, in the long-term care facility that sits by the nursing station, kind of saying to everyone that goes by, "Help me, help me, help me, help me," and there's really nothing that truly consoles them, but that's maybe the way for them to get some attention. Like I said about agitation and even aggression, these are words that we commonly use in our daily lives, and they mean different things to different people. So understanding what someone means when they say, she's just really crazy, or she's turned mean, what does that really mean? What are they, you ask them to describe it. But we've looked at this qualitatively in multiple different studies. And basically, this is where it starts, and this is where it centers, and that is, can the patient, or most often the care partner, communicate to the provider that something is going on and that something is distressing, that it's causing major problems, and that something needs to be done? We lack consistent terminology. And you would think that, when somebody says, they've gone psychotic, well, that doesn't necessarily mean that that person, a lay person, is describing that they have hallucinations, visual or auditory, or that they are delusional, that they're paranoid, et cetera, et cetera. That may just mean that they are hard to handle. So it's very important to kind of understand. What are some common caregiver terms or care partner terms? So when they're describing agitation, they may use the words anger. He or she is upset. They're having meltdowns. They get frantic. They're always so restless. They're flying off the handle. They're unruly. He just roars and constantly angry or gets angry over nothing. Repetitiveness, that can be, he's always asking, oh my God, I told him this a minute ago, and here they go again, and it drives me crazy. So I end up yelling at him, and that doesn't turn out well. They're constantly doing this, does this over and over. That's what we often hear. And what about physical aggression? He can't sit still. He's banging on the table, slamming the doors. I go by, he grabs, he pinches, he strikes. So what is also a problem is that we lay people are aware that Alzheimer's disease is a disease of memory, that someone can't remember. They may not remember longer who they are or who you are. They forget what happened earlier, that they need assistance with activities of daily living. But they often don't have a good understanding that neuropsychiatric symptoms or behavioral changes are part of the picture. So they don't know if this is something that they should be concerned about. They don't know if this is just something between them and their loved one. They often will kind of shamefully say, I don't know why he's turned so mean and why he's doing these things. I do something for him all day. You don't know what I've sacrificed. And then there's no thanks, and he's just mean, and he yells at me, and he pushes and doesn't want to do things. Sometimes they think that this is even part of just normal aging. Oh, you get cranky when you get older, or that someone is just being difficult. This is a statement in a study that a care partner of someone with notable agitation and aggression said. If he'd had a fever, I would have known what to tell the doctor. But at first, when he just acted more belligerent than he used to, I didn't know, I don't know what I would have called it. And I didn't even think that that was a medical problem or that I should bring it up to the doctor or the providers. And so what happens so often is that this festers until there is a true crisis and someone has basically either the behavior escalated and became dangerous, or someone is just completely burnt out. And that's a problem. We need to be have our eyes and ears open to catch this preferably earlier. So family members are often also very ashamed of this. They think that they have failed. They don't want to, rat out their loved one. They are, they describe being in denial. They are say, I was just hoping that tomorrow it would be better. This, and how could it get worse? So, let me just live with this. They wanted to avoid the stigma of this. And they also were often very afraid to bring this up in front of the patient. Can't tell you how often people say, ask, can I speak to the doctor alone in our clinic? And we usually know that there's something like this that they're then going to bring up. They're also not aware of some of the techniques and resources that may be available in their community. So that this is actually so common that the majority of people with dementia have some sort of a neuropsychiatric symptom, very often agitation or aggression at some stage during their disease. They don't know that there might be strategies like distraction or redirecting. We'll talk more about that a little bit later, that can be applied. And they often just think, oh, probably nothing can be done. This is just one more thing that makes this situation just unbearable. We need to focus on basically educating people what's going on. So let me try to illustrate some of this with a patient case, because I find that that's often helpful. So in this situation, and I'm going to point out this was not one of my patients, but I've seen a lot of people like this one. A 74-year-old female with moderate Alzheimer's disease presented for follow-up, accompanied by her daughter and son. Always illustrative when both a daughter and particularly an adult son come in. The patient lives with her daughter and son-in-law, no apparent physical changes in health, or new medical symptoms since the last visit. That was 3 months ago. The patient basically says, today is my latest, greatest day. There's nothing wrong. I have no memory problems. I function completely independently. But the family reports that starting actually before the last visit, there's been increased oppositional resistiveness, increased irritability and frustration, that now mom has started pacing, is constantly restless. And after an argument with her daughter, the neighbors kind of saw her wandering out by the side of the road and called over and said, do you know what's going on with your mom? And that's what brought about this visit. So appetite had been stable, weight was stable. She needed structure and reminders about activities of daily living. She was sleeping well. There had been no falls. Current medications, she had a long-standing history of mild depression that had been successfully treated with paroxetine, 20 milligrams daily, and was also on donepezil, 10 milligrams daily for her Alzheimer's disease. So basically, let's think about the fact that we need to define what's going on. We need to understand better, what are some of these behaviors, and maybe put a yardstick on them. How frequent are they? And when they happen, how intense are they? And it used to be that we would have no kind of guidelines for this. And in 2014, we got together. I'm one of the author of the diagnostic criteria for AAD that the IPA put together. And that was so that we could share a common language on one hand, and also so that we could basically identify a group with somewhat similar symptoms that the Food and Drug Administration would then find this as an indication, a treatable syndrome. So basically for the IPA definition, so first of all, the patient needs to have a dementia syndrome or significant cognitive impairment. They also need to have at least one domain of agitation or more that is persistent and frequent, has been going on for at least 2 weeks, and is a change from the usual behavior of that person. That the behaviors are severe and that they are associated with distress, not just for the caregiver, that it's just not bugging the caregiver, but that there's some sense that this is distressing the patient as well. Because if you're going to intervene, particularly with pharmacotherapy, we need to be doing that guided by the fact that the patient needs that. And that the behaviors are bad enough that they cause increased disability beyond what just the cognitive impairment should bring about. And that the behaviors are not solely attributable to another psychiatric disorder. For example, if somebody has a bipolar disorder and it bubbles up, or a severe exacerbation of their depression, a medical condition that could be an infection, pain syndrome, or anything that causes a delirium, suboptimal care condition, so that the person is agitated because they're not getting the care that they need, not being taken to the bathroom when they have an urgent sense to go, etc. Or that they're using some sort of a substance. That could be alcohol or inappropriate medications, etc., etc. The examples of the agitated behaviors, we've mentioned them before, but let me rehash them again. So excessive motor activity, what are those? Pacing, rocking, gesturing, pointing a finger, and general restlessness or performing repetitious mannerisms. Verbal aggression, yelling, speaking excessively loud. I hope I'm not doing that. Using profanity, screaming, shouting. Physical aggression, grabbing, shoving, pushing, overall resisting, and hitting others, kicking objects or people, scratching, biting, throwing objects, hitting themselves. So it's not just aggression towards others, but it can be aggression towards themselves. Slamming doors, tearing things up, and destroying property. So what are some of the tools that we can use? In the clinical trials, we use a lot of the Cohen-Mansfield agitation inventory. That's a 29-item scale that takes way too long. You know, to do that appropriately, it takes about 30 minutes. Nobody can do that in clinical practice. The NPIQ, the Neuropsychiatric Inventory Questionnaire, is often recommended. The problem with that is that I see that as a better kind of a measure of broad-based behaviors, because look at this. There's a single question for apathy or indifference. Does the patient seem less interested in their usual activities? Sorry, got the wrong one. Is the patient stubborn and resistant to help from others? That doesn't even begin to capture the symptoms that I've been talking about recently. So I find that the NPIQ is the best assessment for agitation. And because of that, Carolyn Clevenger put together a very, very good scale that was recently validated. And that is the AASC, or the Agitation and Alzheimer's Screener for Caregivers. What I love about it is that it's a one-pager. You can give it to the care partner when they're in the waiting room or when you might be seeing the patient, and they can fill it out. You can also use it in the office to quickly, check for these symptoms. Do they have any of the following? Repeating motions or behaviors such as rocking, racing, fist pointing finger. Do they have pacing or restlessness? And then you can explain it, cannot be still. Cursing, profanity, or lashing out verbally. Raising voice or yelling or screaming. Resistant assistance or care. Throwing or hitting or breaking things. Trying to hurt self or others, like grabbing, kicking, hitting, biting. And if any of this is a yes, do any of these behaviors negatively affect the individual's relationship, activities, or willingness to receive care? And if that's a yes, then you've basically met the criteria for the IPA definition. And I find this scale very good. This is a busy slide, and I just want to hit the highlights here because, first of all, your eyesight might be better than mine, but it's still a busy slide. So the decision tree for the healthcare provider, I think that we need to proactively ask about if there have been some neuropsychiatric symptoms. And what I ask is usually some general question like, have there been any behavioral changes for John? Have there been changes in his behavior? And if they say, no, he's just like usual. If they say, what do you mean, doc? Or what do you mean by that? And then I may say, are there any behaviors that you're concerned about or that make caring for your loved one more difficult? If they say no, well, you can kind of leave it. If they say yes, he's got a short fuse. He gets upset so easily. There's nothing that I can do that doesn't kind of tick him off. He's irritable, angry, restless, can't sit still. So, again, if you are not sure what they're talking about, ask them to describe what's going on. You might use a behavioral scale. The NPIQ, maybe. I like the AASC myself. And you need to kind of make sure that you evaluate this, not just kind of how frequent it is and how troublesome it is, is it present? But also, if it is present, has there been any kind of change in his or her medical condition? Has it been complaining of pain? Do they have any problems with the respiration? Are they going more often to the bathroom? Did this happen very suddenly? And, are their vital signs stable? Has there been, is there a lifetime history of depression? Does this look like their previous episodes of depression? Are there hallucinations or delusions with this? Are there any environmental factors? I remember one of my earliest kind of patients in a nursing home setting, and my teacher at the time said, you got to ask about this, because their behavior might have much more to do with their roommate than their dopamine receptors. Sometimes this was back in the days where you would be in a nursing home and there would often be a shared room. And if you get put into that situation with someone that annoys the heck out of you, well, maybe that would be a better solution than a drug. So if you find something, treat it and see if that resolves the behavior. If there's nothing that medically seems to be wrong, the first line of treatment is to basically, try to explore. Is this due to kind of friction or poor communications and interactions between the care partner and the patient? Do they think that this is just, are they angry? Are they upset? Because he is just mean and unthankful, and so I give him the cold shoulder. And can this be approached differently? Have they tried, when this begins, to distract the person? Usually, hey, let's go to the kitchen and see if maybe we'll have some ice cream or something. If that doesn't work, or if the behaviors are very significant and intrusive, particularly if there is aggression, you probably have to go to pharmacotherapy. So let's get back to the case. So the patient, she did not have a fever. Vital signs were stable. And the physical and neurological exam was basically normal for age. What happened during the visit is that the patient became very agitated. I didn't need to be here. I didn't want to be here, and you forced me to come. You're always, telling me what to do, and can't stand it. So basically started yelling, and it got so bad that she started hitting her daughter and her son. And nevertheless, basically, we're able to get a mini-mental state exam, which was done prior to everyone coming in for the visit. Moderate impairment with a score of 15/30. The evaluation also revealed no evidence of delirium. Asking about depressive features, because remember, she had a history of depression and was on paroxetine. Basically, a fairly low score on the Cornell scale, and more associated with agitation and aggression. So the preliminary diagnosis was agitation due to dementia. also a well-established diagnosis of Alzheimer's disease, or you can combine that if you're not sure into senile dementia with behavioral disturbance. So what are some of the treatment options that we could apply here? Let's kind of look at that. And there. What are some non-pharmacological strategies? Because I pointed out, you should try to employ those. So the behavior is distress, and this change in behavior is not only distressing to the patient, but also very frequently to the care partners. And so educating them, pointing out that this is common, and recognizing that this is troublesome. We don't try to normalize it. Oh, this is just what you have to live with. But basically education that this isn't personal. This isn't directed at them. This is not just a lack of gratitude, but a change in behavior that we see associated with the neurodegeneration of the disease, where certain centers in the brain are damaged and certain neurotransmitters are skewed out of balance. So what can you teach the caregiver? Look at how they interact. Encourage them to try to understand, the limitation that the patient has in terms of understanding what's going on. And is there some way to enhance communication skills? Can you de-escalate a situation, for example, with distraction, or kind of engage people in activities? I already talked about educating about the disease, and often helpful referring people to community support groups, like through the Alzheimer's Association. What about the patient? Encourage people to engage in structured or even unstructured activities. To avoid understimulation, just let them sit in the corner until, they get bored and blow up, or overstimulate them. Some things that people talk about: hand massage, therapeutic touch, exercise. I often find helpful. Music. Music is something that you retain long into dementia. I can't tell you often people say, I never knew that my dad enjoyed music so much. We can play music from his era, and he sits down, he calms, he sings along, and try to understand what made this person tick. Can you somehow bring something in to distract them that is along their interests or their hobbies? Supervised outdoor time, and we can talk about exercise again. What about when non-pharmacological interventions aren't sufficient, or the behaviors are kind of more than moderate or higher in intensity, or very frequent? We got to look at pharmacotherapy. So this has been, a challenge as long as I've been in medicine, and long before that. So one of the things that you want to do is you want to look at the medications that someone is on where behaviors emerge. For example, paroxetine is quite anticholinergic, would probably not be my favorite antidepressant, even if someone had been on it for 20 years. Now, when their brain is kind of broken and the cholinergic system is particularly impaired, a drug that is that anticholinergic, especially if they're on other medications that additionally add to the anticholinergic load, that might not be it. If we look at what is being used, we've used a lot of different medications: benzodiazepine, conventional antipsychotics, atypical antipsychotics. Benadryl is still being thrown about. We can use antidepressants. We see people use trazodone, SSRIs, but the only medication that is approved for this indication by the FDA is brexpiprazole, which is a second or third generation atypical antipsychotic. and is now FDA approved since 2023 for the treatment of agitation associated with dementia due to Alzheimer's disease. What that means is that any other treatment is off-label, and also means that if you choose a different treatment, I think it is now, imperative for us to point out there isn't an FDA-approved treatment, but for many reasons, that might be cost or that you think something else might work better, that maybe you choose something else, but that the patient and their caregiver's family are aware of this and that they agree with a different choice. So what about antidepressants? Calming antidepressants may be useful in mild and intermittent agitation, so trazodone as needed. We've done studies with mirtazapine. It didn't work as well as we thought. A group that I was the leader of looked at citalopram and found it to be effective. And there was early indications there that escitalopram might actually possibly be safer because citalopram worked well, but was associated with QTc prolongation, fairly mild, but still there, and a slight decline in cognition and a worsening of balance. So we thought that escitalopram might be better, but we just got the results. And disappointingly, there's nothing that convincingly shows that escitalopram is superior to citalopram. May not be. This is brand new data. We just presented the top line results. So let's get back to the patient case. The treatment plan was to refer the patient and family to a social worker for the psychoeducation and non-pharm interventions. The provider discontinued the paroxetine and switched the person to escitalopram, 10 milligrams daily, continued the donepezil, and scheduled a follow-up in 1 month. I would maybe have done this differently. The question here is, at what point should antipsychotic treatment be considered? I might have gone with that because of the level of aggression that we saw here. For brexpiprazole in particular, it was patients that were agitated but had aggressive components that responded particularly well. So brexpiprazole, again, is the only FDA-approved treatment. Other atypical antipsychotics, such as quetiapine, are off-label, commonly used, but off-label. We have not been able to show consistent efficacy, and we have a myriad of side effects, such as the boxed warnings that we've heard to. What is the boxed warning? Increased mortality, increased cerebrovascular events are the main things. It doesn't mean that these drugs aren't commonly used, but you need to educate the patient and family about this potential side effect. Here's basically the boxed warning, but I talked about that a little bit already. The American Psychiatric Association practice guidelines basically suggest that antipsychotics should be used for treatment of AAD only when symptoms are severe or cause significant distress to the patient and or pose a danger to the patient or others in the environment. Before initiating a conventional or atypical antipsychotic, assess and discuss potential risk and benefits to the patient surrogate, and get their approval for this. And if there is no clinically significant response in 4 weeks on the dose that you think is indicated, you should taper and withdraw it. So brexpiprazole is a third-generation atypical antipsychotic. What does that mean? It has actually kind of a minimal dopamine antagonist effect. It is a serotonin dopamine modulator, so it's a partial agonist of serotonin 5-HT1A, and basically a partial agonist on the dopamine receptor, so not a dopamine blocker. It is also an antagonist of serotonin 5-HT2A and norepinephrine receptors. So a mixed pharmacology. The main data for this was from 3 trials, basically 210, 211, and study 213. And it's the 213 study that is maybe most revealing and shows that brexpiprazole at 2 and 3 milligrams was superior to placebo. You start the treatment with 0.5 milligram for 1 week, 1 milligram for 1 week, and then you go up to 2 milligrams. And if you need more, then you can go to 3 milligrams a week or 2 later. Was a fairly large study, 12 weeks of observation. The primary endpoint was the CMAI total score and multiple secondary endpoints. And basically, you see that once the drug is at the therapeutic dose 2-3 weeks in, you begin to see an effect where we see the things start to separate at week 4, and that separation becomes more notable at week 6, but more so notable at week 12, and it continues to separate in the longer studies, open label extensions. And that is both in direct measures of agitation as well as in a clinician measure of severity. Safety overall fairly good. Discontinuation due to adverse events slightly higher with Brex than placebo, 5.3 versus 4.3, so only a 1% difference. Both groups had similar incidences of falls, sedation, extrapyramidal symptoms, that Parkinsonian features, cardiovascular events, cerebrovascular events, or metabolic events. So what were some of the things that you saw? Drug was associated with slightly higher risk of somnolence, nasopharyngitis, slightly higher risk of dizziness, asthenia, GI, diarrhea, and urinary tract infection. No difference, like I said, in falls or really in akathisia or EPS to speak of. Cannabinoids are getting increasing attention, and many people are now going either to the dispensaries or where cannabis is legal to get gummies for grandma. So there's some data to suggest that this may be helpful, not for everyone, but for some people. The more data is coming out. We'll see a large study that just completed for this. Other things, dextromethorphan, that is blocked, where the metabolism is blocked by bupropion, is showing effect as well, showed an effect in a double-blind placebo-controlled study, and also in basically, that's this one that showed a separation on the CMAI, and also in a study where they began with open label treatment and 80% responded, and then they were randomized to continuing on drug or going on placebo. And the group that went on placebo clearly had a more relapse than the group on drug. Desmetanide is used for agitation in people with schizophrenia and bipolar disorder, and is being looked at here. And that's a thin film kind of buccolingual drug that mostly would, if you indicated approved, would be for acute agitation. So the key takeaways here is basically that more than 50% of Americans diagnosed with Alzheimer's disease at any one time have neuropsychiatric symptoms of agitation, aggression, or apathy. We can throw that in there as well, affecting quality of life of patients and caregivers. Not all of these are significant enough that they warrant a treatment intervention. But in about 20-25%, you need to intervene. And caregivers are often unaware of this being a problem that they should bring to the provider, or how to describe it. So we kind of have to help them a little bit with that. And this new scale, the ASC, may be particularly helpful with that. We have one drug already approved. We have multiple drugs that are in the pipeline. And then there are numerous drugs that we have used over the past decades off-label that also in some instances may be beneficial. So let's vote again here with the few minutes that we have left. And basically, post-test 1, which of the following is not one of the International Psychogeriatric Association criteria for AAD? A diagnosis of cognitive impairment or dementia syndrome is required. Behaviors must significantly affect one or more aspect of function. Behaviors must be solely due to a psychiatric disorder, medical condition, or delirium, or the one of or more of the symptoms from categories of agitation must be present. Excessive motor activity, verbal aggression, or physical aggression. Please go ahead and vote. Okay, so I must have, done a good job, but most of you knew this right from the beginning, and that is that it can't be solely due to these conditions. Then that is the reason, and that's what you should target. So very good job both before and after. Let's look at post-test 2. Which statement best summarizes the APA guidance on the use of antipsychotic medications in patients with dementia? Let me point out that these are all things that are smart to keep in mind. But the APA guidelines are very narrow, as I covered. The antipsychotics may be used with no additional concerns in this population. They may be used with reduced maximum doses for patients aged over 65. C, use only when symptoms are severe and cause distress or danger for patients or others. D, use with caution in patients considered at risk for falls and implement additional methods to mitigate risk. Or E, do not use in combination with other pharmacological treatments for behavioral issues. Please go ahead and vote. Very good job. And clearly, the API guidelines suggest using only when symptoms are severe and cause distress. But many, highlighted, other things as well. And no argument from me, because those other things basically outside of A make sense. You use with reduced doses in patients older than 65, consider the fall risk, and then be careful about using it with other pharmacological agents. Finally, post-test 3, which is the only FDA-approved treatment indicated for AAD. Quetiapine, brexpiprazole, dexmedetomidine, and escitalopram. So for agitation in Alzheimer's disease. Which one? Go ahead and vote. Okay, well, I want to highlight that you picked up the fact that Brex is the one approved, and others may be coming. Great job with that. Q&A. I may have, I'm not sure if the timer here gives us questions.
I think we can do a few.
Okay,
A few.
excellent.
So I'm trying to combine a couple of questions here in the interest of time. There's been a bunch of people wondering if you're seeing a patient for dementia, maybe you didn't make the diagnosis. This is only indicated for agitation with Alzheimer's dementia. How do we know if it's going to be appropriate or not? Is there a way to tell, easier?
Yeah, my lavalier mic is working. So understand that the FDA wants a narrow definition. But patients in these trials had a clinical diagnosis. There was no biomarker verification. There was a clinician that said, I think this is most likely Alzheimer's disease. And then they have this behavior. There's no evidence that agitation in other dementias, vascular dementia, for example, or possibly dementia with Lewy bodies would respond differently. So I would say that I would maybe with brexpiprazole be thoughtful about people that have Parkinson's dementia. But in the Alzheimer's disease patients that we studied, there was no real worsening of EPS. So I don't know that you need to be too hung up on the exact diagnosis. Understand that the patients selected into this were clinical diagnoses made by regular providers.
I think that's good to know. That'll make people more comfortable.
Exactly.
Folks were wondering, is Brex less sedating than some other medicines that we may have been more used to using, even if they were off-label, like risperidone or aripiprazole?
It seems to be. So as you saw, there weren't a lot of sedation side effects there. I think it was like 2% versus just about 5%. Whereas, risperidone and quetiapine, particularly quetiapine, we sometimes pick it because it is more sedating. It is a sedating antipsychotic. The problem with risperidone in particular is that it generates kind of this tranquilization and can exacerbate apathy. That's one of the things that I appreciate about brexpiprazole. Some of you may have more often tried aripiprazole, which is kind of Brex is like the younger sibling of aripiprazole, has a different profile and seems to, has better data in agitation. But similar in terms of not a lot of kind of tranquilization or sedation.
And kind of last question we'll get to. Have you found that it is easy to prescribe? Insurances are allowing it. Maybe it's on formulary in places like long-term care centers. And just to clarify, it's something that should be given daily, not on an as-needed basis for the agitated behaviors.
Excellent question. So the short answer is do not use this as an as-needed medication. There's no evidence that it works. And in fact, when you think about the fact that we need to titrate it to the therapeutic dose, 0.5 for a week, 1 for a week milligram, and then 2 milligrams, and then you can go up to 3 if needed, suggests that as needed, not good for that. If you think you can get away with that, probably should pick a different drug. Formularies for long-term care facilities, it varies. Some of them like the fact that it's FDA approved, and in states where there is a lot of kind of medical legal stuff going on, they may kind of prefer it. Coverage varies. Generally speaking, I think that there's coverage, but there's often a fairly meaningful copay. And that's usually if you have an older individual on fixed income that struggle with making ends meet. The copay is likely to be well over $100. So I've heard people talk about 150, 170, and up to $300 copay. So that has been the most common pushback for me when I have suggested this medication in the clinical setting. There are some insurances that cover it more easily. They can't really suggest that you try something else first because nothing else is indicated. But if you, that's again, that's been a little bit my experience, that the challenge may be not that you won't get it accepted if you're clear about the indication, but that the cost is a challenge.
I want to thank you so much. I think this has been an outstanding lecture.
Thank you. I appreciate the kind words.
Thanks. I want to thank all the virtual people as well as all the folks we have here in person. Remind you again to please use the QR code to claim your credits. You want to get credit for spending your time here. And I want to thank MEDX as well as the Pennsylvania Medical Society for putting this on for all of us. Hopefully you've learned something you can bring back to your practice, and we hope to see you again soon. Thanks so much.